And dear delegates, welcome to the day 2 session. So our first session is the free paper presentation. I request Dr. Gautam sir and Dr. Satish sir to chair this session.
Am I audible now? Am I audible?
Yes, sir.
You're
Yes, sir.
audible. You're audible, sir.
Yeah.
Unmute, Suresh.
Yeah. Good morning, everybody. And after a feast of stocks yesterday, so we came here for the second session to start with free papers by the postgraduates. So I call upon each and every person one by one, as there is according to the list. Please be restricted your talk to 8 minutes and give time for approximately 2 minutes for the question and answer session, so that we can conclude the session in a sharp time by 9:30. So Mr. Chandu, Dr. Chandu is ready here?
Yes, sir, I'm ready, sir. Yes, sir.
Yeah. You start sharing your screen and session. First topic, the cancer associated neurological syndromes.
Is the screen visible, sir? So is the screen visible, sir?
Yes, it is visible.
Yes, sir. A very good morning to one and all. I am Dr. Chandu, Senior Resident, Department of Neurology, Ramchandra Medical College and Hospital, Chennai, Porur. And my topic is a cancer-associated neurological disorder. This is an observational study which is studied during the period of November 2018 to May 2019, an 18 months observational study under the guidance of Dr. Shankar, HOD Department of Neurology, Ramchandra Medical College. Introduction. Paraneoplastic neurological syndromes are rare disorders associated with cancer, not caused by direct invasion or metastasis or consequence of treatment. Is an autoimmune in nature. Paraneoplastic neurological syndromes.
Chandu, I am unable to hear your voice. Chandu is audible to everybody? Excuse me.
Audible, Satish, yes, audible.
Audible, sir.
Chandu is audible?
Yes, sir, he is audible, sir.
Satish is audible.
Chandu, I am unable to hear your voice.
So can you hear now, sir? Can you hear now, sir? Hello, sir.
He is very much audible.
Hello, sir.
Praveen, he's audible.
He is audible, sir. He is audible for me, sir.
So shall I continue, sir?
1 minute. Let's Satish sir say something.
Praveen. Hello, Praveen.
Sir, sir.
Satish phone చేయండి.
అదే సార్ నేను చెప్తున్నాను సార్.
హలో
సతీష్ వినిపిస్తుంది అతన్ని.
వినిపిస్తుందా?
వాయిస్ వినిపిస్తుంది అది
సార్ మీ వాయిస్ వినిపిస్తుంది సార్ సతీష్ సార్.
చందూది వినిపించట్లేదు.
ఇప్పుడు ఏం ప్రజెంట్ చేయట్లేదు సార్. ఇప్పుడు ప్రజెంట్ చేయట్లేదు సార్, ఆగాడు. మీరు ఒకసారి మళ్ళీ చెక్ చేసుకోండి సార్.
అంటే నేను మళ్ళీ చూస్తున్నాను. నాది అంటే మనోడిది వాయిస్ ఉంది కానీ మనకి కనబట్లేదు, వినబట్లేదు. స్క్రీన్ షేర్ చేశాడు, బట్ వాయిస్ వినిపించట్లేదు. స్క్రీన్ వచ్చింది ఇంట్రడక్షన్.
ఇప్పుడు మాట్లాడమ్మా సార్ తోటి ఒకసారి. ఆడిబుల్ సార్? సార్ ఆడిబుల్.
Now is it audible, sir? Now is it audible, sir?
No. Yeah. Good.
Okay.
Right.
Shall I continue, sir?
Okay. Yeah. Thank you.
Introduction. Paraneoplastic neurological syndromes are rare disorders associated with cancer and not caused by direct invasion, metastasis, or consequence of treatment. It is autoimmune in nature, and paraneoplastic neurological syndromes often precedes cancer, normally 5 years before the onset of cancer. And onconeural antibodies are seen in only 60% of cases. Incidence of paraneoplastic neurological syndromes is 0.5 to 1% of patients with cancer. Incidence of classical paraneoplastic neurological syndromes is less than 0.01% of patients with cancer. The aim of my study is to study the paraneoplastic neurological syndromes, which is presented to our hospital, Ramachandra Medical College, from November 2018 to May 2019. So we have a diagnostic criteria for paraneoplastic neurological syndromes or a cancer-associated neurological syndrome. It's divided into definitive paraneoplastic syndromes and possible paraneoplastic syndromes. So definitive paraneoplastic syndromes is classical syndrome. What is classical syndrome? Is actually the classical presentation like limbic encephalitis, or the classical presentation like opsoclonus, myoclonus like picture, or a correct cerebellar ataxic like presentations, or sensory neuronopathy like presentation with diffuse areflexia and pseudoathetosis like presentation. And when cancer within 5 years of onset is considered as a definitive paraneoplastic syndrome. The other category under definitive paraneoplastic syndrome is non-classical syndrome plus onconeural antibody being positive and the cancer within 5 years of onset of disease. And classical, non-classical pattern of definite paraneoplastic syndrome plus well-characterized antibodies with no cancer comes under the third category of definitive paraneoplastic syndromes. So what is possible paraneoplastic syndrome? It is classical syndrome plus no onconeural antibody or no cancer, classical, non-classical plus partially characterized antibody plus no cancer, and non-classical syndrome plus no onconeural antibody plus cancer in 2 years. So the results, we have a total number of 7 cases, and it is divided as the total of 7 cases, males being 3 and females being 4. 42.8% of males and 57.1% of female, having a female predominance. The disease manifestation, peripheral nervous system manifestation and central nervous manifestations are there. A total of peripheral nervous manifestation, we had 4 patients, that is 57.1%, and central nervous system manifestation, a total of 3 patients, under 42%. And type of paraneoplastic syndrome, it is classically seen 4 and non-classical of 3. And onconeural antibodies were done for 4 patients, and of which positive was 3 patients and negative was 1 patient. So the onset of disease, most of the patients presented to our hospital was like a chronic presentation of being 72%, acute and subacute percentage of being 14% of each. So malignancy diagnosed was ovarian malignancy, breast cancer, small cell lung cancer, and non-Hodgkin's lymphoma, and common malignancy being ovarian carcinoma of being 40%. So these are the 7 patients. It is divided into age categorization, the duration of illness, whether it is an acute, subacute, or a chronic, or a clinical features, the immediate clinical diagnosis, the imaging features, whether PET or CT or other imaging criteria, and antibody for onconeural cells and types of paraneoplastic syndrome, whether it is a definite, probable, or a possible type of a picture. So first patient was a 45-year-old female who presented with a chronic duration of 2 months with a clinical picture of nystagmus, truncal ataxia, gait ataxia, finger nose test and finger nose test being impaired. A clinical diagnosis of pancerebellar lesion was made, and a patient had an imaging criteria being positive for breast cancer and an antibody, onconeural antibody, being positive for anti-O antibodies, and it comes under the definitive criteria of paraneoplastic syndrome. The next is 65-year-old female. Duration of symptoms was acute of 10 days. presented with nystagmus, truncal ataxia, gait ataxia, finger-nose finger, and finger-nose test being impaired on examination. A clinical diagnosis of pancerebellar lesion was made. We've done a CCT abdomen which picked up an ovarian mass, and antibody for anti-O was positive for the patient and comes under definitive paraneoplastic syndrome. The next is 55-year-old female with a chronic presentation of 6 months and presented with the proximal weakness of all four limbs with heliotrope rash and Gauthron's papule. And with the clinical picture, we came to a diagnosis of dermatomyositis, and an USG abdomen, CT abdomen was done, which picked up an ovarian mass, and an antibody came negative. We have sent for anti-TNF gamma antibodies, came to be negative, and definitive paraneoplastic syndrome was made. And the next fourth patient was a 64-year-old male, and we presented with 18 months onset of a distal weakness of lower limb, decreased pain and temperature up to middle of the leg. Reflexes and ankle reflexes were lost and knee was decreased. A clinical diagnosis of chronic sensory motor neuropathy was made. We done a PET imaging which seems to be normal with antibody being anti-amphiphysine positivity, and it seems to be a type of definite type of paraneoplastic syndrome. Next case, the fifth case, this is a 65-year-old male who's presented with the disease progression 1 year with behavioral and memory disturbances, with clinical picture coming under frontal temporal dementia and rapidly progressive dementia. We have done a PET imaging which picked up a lung lesion and antibody becoming negative with coming to a possible cause of paraneoplastic syndrome. Next, we have the sixth case, which is 44-year-old male, disease progression of 1 year, and the presentation was paresthesia, weakness of proximal and distal muscles, more of a proximal involvement. A CIDP-like picture was made in a clinical diagnosis, and we investigated for CIDP. We're not able to find the exact cause for this weakness, like a CIDP-like presentation. Done a bone marrow biopsy, which picked up a non-Hodgkin's lymphoma, and antibody was found to be negative. And since antibody negative seems to be under that category of possible type of paraneoplastic syndrome. The seventh patient was a 44-year-old female, which with a disease duration of 3 months, which has an asymmetrical sensory loss, joint position sense loss in all joints, and diffuse areflexia. A sensory ganglionopathy, like clinical diagnosis was made, a PET being normal and antibody negative, comes under a possible type of paraneoplastic syndrome. So the discussion is, we have compared our studies with other studies. My study, it had a total of 7 cases, and the observation of made of nearly 18 months, and age being for all patients greater than 40 years, and female predominance of male of 0.75:1, and chronic presentation was most common with 72%. Peripheral nerve system manifestation was more common than the central nerve system manifestation, and being 57.4%, and onconeural antibody positive. Total of 4 patients were done, of which 3 were positive. That comes under 75%, and classical type of paraneoplastic syndrome between 57.4%. We compared with other studies, Hannigan and Nanam et al., and they had a disease duration of, they have a total of 45 patients of disease duration being 8 years, the age being more than 40 years. Our study is correlating with age being greater than 40 years. Here they're having a male predominance of 1.25:1, and chronic presentation being 42.2%. We had a more of chronic presentation, nearly 72%, and peripheral nerve system manifestation was being matched with our study, is being 64% in Hannigan et al., and ours being like 57.4%. And onconeural antibodies, out of 14, they've done 10 out of 14, and 58.8% of onconeural antibodies being positive. And they have a classical type of paraneoplastic, fitting only to 48.9%. The next study we compared with Amy M. Chan et al. With a total of 50 patients, and the 10 years duration of study was continued in the study. The median age of being greater, being 57 in Amy M. et al., and having a female predominance as our study being 1.8, and male being 1, and chronic presentation being 88%, with a peripheral nervous system manifestation of 68.2%, and onconeural antibody being positive of 13 out of 25 or 52%, and a classical type of paraneoplastic presentation of 60%. What are the limitations in our study? The sample size is being a total of 7 patients, and the short period of study of 18 months from November 2018 to May 2019. And my conclusion is classical paraneoplastic neurological syndromes are seen in 4 cases, while non-classical syndrome in 3 cases. Central nerve system manifestations are seen in 3 cases, and peripheral nerve system manifestations are seen in 4 cases. Onconeural antibody positive seen in 3 out of 4 cases, and most common malignancy is ovarian carcinoma in our state. Thank you.
Okay. Thank you, Dr. Chandu. You are completed in 10 minutes actually. Okay. The thing is, I have one patient who is having a frontotemporal dementia as presentation.
Yes, sir.
Was it described previously also in any case reports or any specific?
So frontotemporal dementia, like most of the patients being 1 year with rapidly progressive dementia,
Okay.
Rapidly progressive dementia was being reported, but FTD like presentation with behavioral disturbances were not much reported.
What is the
Chandu?
for that? Any antibody described?
Most probably with the rapidly progressive dementias, we have to with the psychiatric disturbances and memory mostly present like a limbic encephalitis, like which are mostly antibody anti-NMDR receptors most common.
Limbic encephalitis presentation is something different than this, no?
Yes, entirely different. They have rapidly dementia with seizure being most common, sir. Seizure and rapidly progressive dementia.
Chandu.
Yes, sir.
Satish, I have one question to Chandu.
You have one question?
Yes, sir.
Yes, sir.
Satish,
Yes, sir. Yes, sir.
I would like to ask a question with your permission. Chandu,
Yeah, you can go.
Yes, sir. Yes, sir.
you have diagnosed that Satish has asked that limbic encephalitis. How you distinguish from autoimmune encephalitis? What test you have done? How did you rule out autoimmune encephalitis in that case? And the second question, the TADP case, did you do biopsy? And what about MRI in case of that paraneoplastic cerebral degeneration? Who faces your PCD? What about MRI findings in that and CADP biopsy? And how you distinguish this limbic encephalitis, which is present as rapidly progressive dementia versus autoimmune encephalitis?
Yes, sir. So first of all, limbic encephalitis and differentiating from autoimmune encephalitis. Limbic encephalitis in autoimmune encephalitis, they mostly present mostly like rapidly progressive dementias. Along with that, the patient can have
differences. How do you do this?
Mostly.
How do you distinguish? Autoimmune encephalitis.
But anti-NMDR receptor antibody should be positive for autoimmune encephalitis presenting like classical. One of the categories is limbic encephalitis.
Not must, Chandu.
Yes, sir. Mostly subacute onset of presentation will be there in autoimmune encephalitis.
Yeah, that's true. Because the presentation here it is 1 year, no? That is uncommon with.
Yes, sir.
That is without treatment.
Yes, sir.
Okay, one is onset. You tell 2, 3, 4 quickly. One is onset too.
One is onset, and then the rapidly progressive nature of autoimmune encephalitis, more like presentation with dementia, which is being rapidly progressive, and mostly they have a seizure-like presentation.
Both are rapidly progressive.
Yes.
What type of seizures?
Faciobrachial seizures are VGKC LG1. Faciobrachial dystonic seizures.
Okay.
Yes, sir. And
What
even
is
GABA A,
your
GABA B
autoimmune
autoimmune encephalitis. GABA A, GABA B autoimmune encephalitis, which is more resistant to treatment with seizures. Sir.
Have you done MRI in the patient?
MRI was done.
MRI.
We are not able to pick up any lesions in the temporal or any.
What will you see in autoimmune encephalitis?
Mostly, we'll be able to pick up some T2 flare hyperintensities over the temporal region, most commonly. But in case of NMDR receptors, we won't be able to much pick up.
You are not presented MRI in any case. About biopsy in CADP?
So we have violated all basic investigations, sir. MRI.
That is not a basic investigation. Biopsy is not a basic investigation.
Biopsy is not a basic investigation, sir. Biopsy
so
was
what
done
about
as a
biopsy
last.
In that case, I'm asking the report of biopsy. In that case, which you diagnosed CADP as a paraneoplastic neurological disorder, I would like to know the biopsy report. Have you done or not?
We have done, sir. We have came to
so
be like Hodgkin's lymphoma.
Is it axonal, demyelinating?
It's NCS was done. It seems to be like demyelinating pattern, sir. Demyelinating pattern.
So with the demyelination, you're suspecting paraneoplastic.
It came to be like biopsy came to be like Hodgkin's lymphoma.
No, not asking bone marrow. I'm asking about peripheral nerve biopsy, not bone marrow biopsy.
Yes, sir.
Okay.
Chandu,
Yes,
in your case, it is ovarian carcinoma is most common associated, no?
Association.
What are the rest of the studies show?
Rest of the studies, mostly ovarian carcinomas are common. most of the pictures are being like cerebellar degeneration with being anti-O positivity, having a ovarian carcinomas being common, sir.
Okay.
Okay, Dr. Chandra, sir. Okay, time is getting late. So we'll move on to the next topic by Dr. Bhavani. Impact of COVID-19. Are you ready, Bhavani?
Yes, sir.
Yeah. Proceed. Please proceed.
Am I
Share your...
audible, sir?
Yeah. Good. Go ahead.
Yes. Is it visible, sir, my screen?
Yes, Amma.
Good morning, all the chairpersons and delegates. I'm Dr. Bhavani Madhuliri from Nizam Institute of Medical Sciences, Hyderabad. Today, I'm going to present a paper on impact of COVID-19 on the frequency, spectrum, and outcomes of the Guillain-Barré syndrome, a single-center ambidextrous cohort study. Coming to the introduction, Guillain-Barré syndrome is an acute polyradiculoneuropathy which presents with varied clinical features, including quadric paralysis, neck weakness, and bifacial weakness and respiratory involvement. Usually, it is treated successfully with IVIG or plasmapheresis. Recently, several case reports of GBS have been published in connection with COVID-19 infection, which was published in NAGM Journal and Muscle and Nerve Journal, and also Journal of Neurological Sciences. We observed an increased number of GBS cases visiting to the neurology OPD and IPD during the COVID-19 pandemic when compared to the last year. So this study was primarily conducted to see whether COVID pandemic caused the increase in frequency of GBS cases and to study the clinical spectrum of cases presented during this period. The aims and objectives is to find out the demographic, clinical features, management, and outcome of patients with GBS admitted during the COVID pandemic that we took as a 6-month period from March 1st to August 31st, 2020, and compare it with those admitted for the similar duration 1 year before, that is from March 1st to August 31st, 2019. It was conducted in Nizam's Institute of Medical Science, Hyderabad, and the Institutional Review Board of NCC approved the study protocol. It is an ambidextrous observational single center study. We use a specified protocol for data collection involving 2 defined periods in pre-COVID and COVID pandemic. Coming to the study population, all the inclusion criteria, all the patients who satisfy the criteria of NIMS criteria for the GBS were included in the study, and also hospital admission within 4 weeks of onset of weakness was also taken as an inclusion criteria. And all the patients informed consent was taken. Exclusion criteria is a subacute inflammatory demyelinating neuropathy, toxic neuropathies, and vasculitic neuropathies. Data was collected retrospectively from March 1st to August 31st, 2019, and prospectively from March 1st to August 31st regarding demography, antecedent events, neurological symptoms, and signs of GBS at study entry, and disability scores at discharge from hospital and at 3 months. Disability was assessed using MRS scale and also GBS disability scale. Nerve conduction findings and treatment given were recorded for all the patients. Statistical analysis was done using SPSS version 20, and p-values were calculated using proportion test, and p-value of less than 0.05 was taken as significant. Coming to the results, though it is GBS, we know that common age of distribution is the younger patients. During pre-COVID time, around 63.8% of the patients were less than 40 years of the age, whereas there is a slight increase in incidence in younger patients of 73.6% of the patients were less than 40 years during the COVID pandemic. These are the other demographics showing the sex distribution. In both the periods, males has predominated the picture. And in COVID pandemic, around 93% of the patients did not have any antecedent events prior to the onset of the symptoms like fever, URTI, or gastroenteritis. Coming to the clinical characteristic, the pattern of weakness during COVID pandemic, there is a slight increase in pattern with the only weakness of both the lower limbs when compared to the pre-COVID period, which is statistically significant. Here we can see that the percentage of patients who present with all 4 limb weakness during pre-COVID time was 86%, whereas there is slight decrease to 61% during the COVID pandemic period, which is statistically significant. And also there is increase in frequency of the patient presented with the both lower limb weakness only. And sensory symptoms and autonomic symptoms were not that much significant. And there is increased frequency of patients presented with ataxic symptoms, predominantly sensory ataxia during the pre-COVID time when compared to the COVID pandemic. And coming to the cranial nerve involvement, this is also 47.2% of the patients has the cranial nerve involvement during the pre-COVID period when compared to the 21% of the patients as a cranial nerve involvement in the COVID pandemic period, which is also statistically significant. Here we can see that when compared to the pre-COVID time, during the COVID pandemic, there is a decrease in incidence in facial weakness and bulbar weakness compared to the pre-COVID period. And during COVID pandemic, around 17.5% of the patients had the preserved reflexes when compared to the only 2.8% of the patients during the pre-COVID time. And also number of patients requiring intubation were also lesser during the COVID pandemic, which is indicated by lesser disability during the COVID pandemic period. Coming to the electrophysiology, axonal variant has seen in majority of the patient during the COVID pandemic, that is 85.97% when compared to the pre-COVID time. And also pure motor picture has predominated the picture during the COVID pandemic when compared to the pre-COVID times. Coming to the disability assessment, the disability score was actually 4 in pre-COVID times. That is 4% of the patients had more disability indicated by the disability score of 4, which is statistically significant when compared with the COVID pandemic period. And the treatment received was also 83.3% of the patient has received IVIG during the pre-COVID time when compared to the only 50% of the patients received IVIG during the COVID pandemic period. And around 40% of the patients received only symptomatic treatment. And the MRS score at discharge was also on the favorable side during the COVID pandemic period. Around 57.9% of the patients had MRS score of 2 when compared to 38.9% of the patients of score 2 in pre-COVID time. This was the same thing depicted in the pictorial diagram. We can see here during the pre-COVID time, the GBS disability score of 4 is seen in majority of the patients when compared to the COVID pandemic. And the MRS score, which is showing a better outcome in during the COVID pandemic, MRS score of 2 was seen in 33 patients during the COVID pandemic when compared to the 14 patients during the pre-COVID times. And after 3 months follow-up, the GBS disability score is 0 in 59.6% of the patients, and around 60% of the patients are without any symptoms during the post-COVID time. That is, which is also statistically significant. Same was depicted in the pictorial diagram here. The GBS disability score of 0 was seen in the 3 months period in around 34 patients during the post-COVID time. So discussion, the study showed an increased number of GBS cases, around 57 cases versus 36 cases during the pre-COVID time. Most of the patients were young males with predominantly lower limb weakness and less associated cranial nerve palsies and ataxic symptoms. Nerve conduction study showed majority as axonal predominance compared to the pre-COVID period. And most cases during the COVID pandemic were milder in severity as assessed by GBS disability score and MRS score, and less number of patients required the mechanical ventilation. Many cases recovered only with supportive treatment during the COVID pandemic without IVIG and plasma exchange. Also at 3 months follow-up, more than half of the patients were back to the normal status and healthy when compared to the patients presented during the pre-COVID time. The study limitations is a short duration and it is an observational study. And the main point is that COVID-19 antibodies were not tested in this study.
Okay, thank you, Dr. Vani. We have also seen the number you are documented. The thing
So
is
there's one
here,
question.
yeah,
Okay.
one question. After that you can ask, sir.
Okay.
Yeah, here, but Dr. Bhavani, are you there?
Yes, sir, I'm there.
In your study, if I am correct, more number of actors are there, but when
Sir,
coming to the
sorry, sir, your voice is breaking.
yeah, am I audible?
Yes, sir, audible, sir.
Yeah. In your case study, more number of axonal variants are there, but when coming to the recovery pattern, it recovered in 3 months. How that compared to the normal GBS with axonal variants, it takes times to recover, you know. But
Yes,
you are
sir. Actually, AADP patients recover better. But, sir, basically, the pattern, 1 minute, sir, I'll show. The axon, when compared to the pre-COVID period, the amount has increased. But when the COVID pandemic, on the whole, there is sensory motor variant is only of the patient had sensory motor variant. But when we compare the pre-COVID time, there is increase in axonal incidence, sir.
Yeah.
Why they improved early? Sir is asking. The axonal, why they improved early?
Early
one point is there in your slides. You showed one point. Most of the cases are mild.
Most of the cases were they presented as a mild variant, sir. All patients only with the lower limb weakness they have presented. That too, not like
Rajesh, can I ask a question?
Yes,
yeah, you can, sir. Sir, proceed. Please ask.
Hello, sir.
Sir, Dr. Gopi, you're not audible, sir.
Sir, Gopi, sir.
Yeah. Hello, Dr. Gopi is not audible.
Sir, may I ask a question, sir?
Yeah, you go
ahead. These studies show that it is axonal and motor predominant, that is the M1 variant is more predominant in this observational study. Is it correlating with the other studies in all over the world?
Sir, actually, I mean, there is varied presentations are there, sir. In NEGM, they have published as axonal variant is more common. But in Journal of Neurological Sciences, they have reviewed around 31 cases. In that, they have described AIDP as the most common variant, sir.
Does that mean that the same pattern what the chain that India and China, where the Amman variant is more predominantly seen, that does holds good for this pandemic also?
Yes, sir. Even I mean, one more study was also showing as axonal variant as only as a common variant, sir. During a pandemic, during this early pandemic experience, they have published some some case reviews only, sir. Case reports around 31 cases.
Did you do any CSF RT-PCR for these cases? Any one of the case?
Sir, CSF we have done for few patients, sir. I mean, majority of patients did not have much data. That's why we have not included. And RT-PCR we have not done, sir. That is the main limitation, actually.
Any antibodies testing?
No, sir.
Okay.
We have collected the samples, but we couldn't do for all the patients, we are not able to do the antibodies testing. That's the limitation of our study, sir.
Okay, Gautam. Next topic.
Yes, sir.
Thank you, Dr. Yeah. Next, Dr. Fani Kumar, are you ready? Dr. Fani?
Hello, sir. I am ready, sir.
Yeah. Please.
Sir, am I audible, sir?
Yeah, you are audible. Start sharing your screen.
Yes, sir. Sir, is it visible, sir?
Yes. Go ahead. Yeah.
Sir, good morning, sir.
Morning.
I am Dr. Padikumar, neurology resident, SWIMS Tirupati, sir. So I am presenting a case of polyradiculopathy mimicking CADP in case of chronic araldite sniffing. So coming to the introduction, recreational sniffing of araldite, a hydrocarbon, it can be associated with potential neurological complications, including polyneuropathy. However, CADP-like presentation of glue sniffing neuropathy has been rarely reported. Peculiar abnormalities and MRI have been reported, and we have reported a 22-year-old male with a history of chronic glue sniffing who presented with polyradiculopathy mimicking CADP. So the objective of this study is to characterize the polyradiculoneuropathy closely mimicking CADP in case of araldite sniffing, and the material methods being a 22-year-old male who came to our OPD and who was admitted with a long-standing history of recreational sniffing of araldite. He was evaluated for chronic sensory motor symptoms in all the extremities with nerve conduction studies, sural nerve biopsy, and MRI brain. And here is the case report. A 22-year-old male coolie by occupation, he came with complaining of ascending paresthesias, started in the lower limbs, started from the foot up to the lower trunk, initially in the right lower limb, followed by left lower limb for the past 10 months, and associated with progressive weakness of the lower limbs for the past 10 months. Initially, the weakness started in the right lower limb, followed by left. So in the right lower limb, initially started distally, followed by proximal. And the paresthesias, they are present in the upper limbs from the tip of the fingers below the elbow, and it is associated with thinning of the hand muscles for the past 20 days before the admission. So coming to the history of present illness, he was apparently normal 10 months back when he initially observed paresthesias in the lower limbs, initially in the right foot up to the lower trunk, associated with gripping in the chappals with the right foot, and there is slippage of slippers were there with awareness. And later he noticed similar complaints in the left lower limb. And this weakness is associated with over a progressive, it was progressive and it was associated with thinning of the lower limbs, but there are no fasciculations or stiffening of the muscles. So for the past 20 days, he noticed paresthesias in both the upper limbs simultaneously, started from the tip of the fingers to below the elbows, and it was associated with thinning of the hand muscles, that is distal, but no difficulty in raising the arms above the head, and there is mild difficulty in getting up from the supine to sitting position. History of buckling attacks were there, and no cranial nerve or bulbar involvement, no bladder bowel involvement. And this is the picture of the Araldate, which he had sniffed for the past glue sniff, Araldate sniffing for the past 12 years. And coming to general examination, it was no pallor icterus, and it was normal. Vitals are normal. Cardiovascular respiratory system normal. Parabdomen is normal. So coming to the nervous system examination proper, patient is conscious current, speech is normal, extraocular movements they are full, pupils bilateral normal says reacting to light, but there is mild element facial pulse. Orbicularis oculi weakness was present bilaterally with tongue having mild atrophy, and there are no fasciculations or no tongue deviation. Tone, there is hypotonia in both upper and lower limbs. Coming to the power, neck flexion and extension is good. Truncal weakness was there. And coming to the upper limbs, proximal, it is proximal shoulder, elbow, and wrist was 4/5 bilaterally. Hand grip is 50% bilaterally. Coming to the lower limbs, both proximal and distal, that is hip, at the level of hip, knee, and ankle, it was 1/5 bilaterally. Coming to the reflexes, so it was almost hyporeflexia in the upper limbs with areflexia in the lower limbs, with plantar being mute bilaterally. So coming to the sensory, pinprick and touch, they were normal. Joint position was intact in the upper limbs, and it is lost up to the toes in the lower limbs, and vibration is reduced distal in both upper and lower limbs. Rhombox and cerebellum and gait could not be assessed because he could not walk and there was weakness. We had a diagnosis of, it is a case of chronic progressive weakness of upper and lower limbs. Lower limbs more than the upper limbs. In lower limbs, distal and proximal weakness there was that was equally affected. And upper limbs distal weakness was more predominant in the proximal, with bilateral element facial palsy with sensory symptoms, with the history of glue sniffing for the past 12 years. And we thought of toxic polyradiculopathy related to the glue sniffing. And we have investigated with routine investigations, and which was normal. ANA vasculitis profile was negative, and only MI2 being positive. CRP is little bit, CRP is elevated, RA factor is negative, CPK is 64, RFDs and thyroid was normal. And we had imaging of the brain, and the brain T2 image showed bilateral thalamic hypointensities. So as you can see in the picture, and with the diffuse cerebral atrophy. So we have conducted nerve conduction studies on this patient, and it showed symmetrical mixed axonal and demyelinating sensory motor neuropathy. And these are the images. This is the median abductor pollicis brevis, where latencies, they are pronged, amplitudes, the Cmaps, they are very much reduced, with velocities, they are also reduced less than 75%. So signifying both the demyelinating as well as the axonal pattern. And this is the peroneal, where the latencies, amplitudes, and velocity, they are not recordable. And this is the tibial, where latencies, amplitudes, and velocities, they are not recordable. And FFs, they are absent from median abductor pollicis brevis. And sensory, they are median, ulnar, and sural, they are absent, they are not recordable. And we have done left rural nerve biopsy, which showed neurogenic atrophy, showing both chronic axonal and demyelinating neuropathy, suggestive of immune-mediated neuropathy. We have sent the sample to the NIMHANS, where we got the report. Patient was treated with methylprednisolone and 5 cycles of plasma exchange. And at the time of discharge, he had mild improvement with power initially, which was 1/5 bilaterally. It improved to 2/5 bilaterally, and he had decreased paresthesias. So coming to the conclusion, hydrocarbon, that is including Araldate sniffing, it can present with chronic polyradicular neuropathy that can closely mimic CADP. A careful history of recreational sniffing and presence of thalamic T2 hypointensity, it provides valuable diagnostic clues in this setting. And this is my bibliography. Thank you.
Good presentation. Satish sir.
Hello, sir.
Hello, am I audible?
Yes, sir. You are audible, sir.
It was a case report, no?
Yes, sir. It was.
Gautam,
Yes, sir.
I
Hello?
could not appreciate the thalamic hyperintensity. Can I show again? Can you ask me to show again the scan?
Again, show the thalamic hyperintensity.
Sir,
Hypo.
hypointensity, sir.
Hypo, I could not see. If that is there, okay, it's good.
Sir, these are the hypointensity.
I am zooming it, but I could not see. Please show.
Sir, can you see the arrow, sir?
The arrow I can see. I'm zooming it also.
Yeah, high point. Yes.
Bilaterally, there was thalamic hypointensity, sir.
Yeah.
Yes.
Okay, good work.
Sir, is it visible, sir?
Visible.
Yes.
Visible.
Yes. Dr. Fani,
Sir.
You are telling is it a polyradicular neuropathy, because the axon here the CMAPs are almost not recordable.
Sir, in lower limbs they are not recordable, sir. In the upper limbs we have, in median we have both axonal as well as demyelinating battery, sir. Because the conduction velocity there is less than 75% of the normal limit, sir.
With that so much reduction in the CMAPs, distal CMAPs, how can you say whether it is the polyradicals are involved or not?
Sir, one thing, sir, F wave, sir.
F waves, how can you do?
Yeah. If lower limb, if motor amplitudes are not recordable, how F wave will
come?
Okay.
How do you confirm that whether it is a real neuropathy or polyradicular neuropathy?
Right. And did you do any post improvement nerve conduction studies?
Sir, which one, sir?
After improving, no? Did you study any? Did you repeat the nerve conduction studies?
No, sir. We have not repeated, sir.
Improvement in only one grade.
Only one grade, sir. From 1/5 power to 2/5 at the time of discharge.
Any blood test to say it is hydrocarbon exposure?
Sir, actually he showed that label, sir, that he had the recreational.
I'm asking, any blood test is there because actually
this is the causative agent.
Sir, actually, the toxic profile, it was not available, sir. Actually, that was not there, sir.
That is there, it is confirmed.
Yes.
Yes.
Okay, right. Funny. Next, we'll go to the next topic.
Thank you, sir.
Yeah. So, next, Dr. Krishna Haskar.
Sir, I'm ready, sir.
Good morning.
Stop
Good
sharing.
morning, sir.
Stop sharing the. Yeah, good. Krishna Haskar, go ahead.
Yes, sir, once. Sir, is it visible, sir?
Yeah.
Good morning, everyone. My name is Dr. Krishna. I'm a senior resident in Neurology Department from MS Ramaya Medical College, Bangalore. Today, I am going to present a case report. It is a neuromyelitis optica spectrum disorder and an adenocarcinoma of ovary. It is a novel association. This NMOSD is a group of inflammatory disease involving the central nervous system and may cause a severe disability. And this paraneoplastic syndrome are remote effects of the cancer caused by autoimmune response that are triggered by tumor cells. In the previous, till now, the literature, NMOSD, the most commonly an idiopathic immune condition, it has been described, and following infections of HIV and EBV have been described. And there were only a few cases of NMOSD presenting as a paraneoplastic syndromes that are associated with B-cell neoplasm, carcinoid tumor, lung carcinoma, and esophageal cancer. Herein, we report a case of a 53-year-old lady with a paraneoplastic NMOSD associated with adenocarcinoma of ovary and which improved with IV methylprednisolone and azathioprine. So this is a 53-year-old post-menopausal lady. She presented with a bleeding PV for 2 months and she was diagnosed to have adenocarcinoma of ovary. She was started on paclitaxel and carboplatin chemotherapy and received 4 cycles of chemotherapy. A few months later, she developed multiple episodes of vomiting, and within 24 hours, she developed sudden onset of weakness in both lower limbs, and she was not able to move her both legs, and she had painless urinary retention and with decreased sensation in both legs. On examination, it revealed paraplegia, power is totally 0, and decreased sensation in both lower limbs till the abdomen, and brisk deep tendon reflexes in lower limbs. On investigation, her blood investigations were normal, CBC, liver function, and renal functions were normal, and HIV and syphilis were negative, and vitamin B12 levels were normal. So we got an MRI, we suspected a dorsal myelopathy. We got an MRI brain and MRI spine done. So this MRI spine showed longitudinally extensive transverse myelitis extending from C3 to D12 levels. And this is an axial cut showing an MRI spine showing the demyelination. And this is a post-contrast image. The CSF analysis, cells were 50, glucose is 67, and proteins were elevated. And CB net for TB was negative, and CSF for malignant cells were negative. So we worked up for immune workup was done, which showed ANA IF was negative, AC levels and C ANCA, P ANCA were normal limits. Her aquaporin 4 antibody was positive, and serum MOG was negative. And she was treated with IV methylprednisolone for 5 days, and oral azathioprine was started. And symptomatic improvement was seen, and her power in lower limbs improved, and she was able to stand and walk with support. Coming to the discussion, the clinical manifestations of NMOSD result from immune-mediated attack on aquaporin-rich regions of the brain through an aquaporin-4 and related antibodies. This aquaporin-4 is also located at extra CNS sites such as intestines, endometrium, kidneys, airways, and skeletal muscles. And this aquaporin-4 is also expressed in tumor cells such as carcinoma of the breast, adenocarcinoma of the lung, thymoma, lymphoma, thyroid carcinoma, and carcinoid tumors. These tumor cells express as onconeural antigen proteins that are normally expressed by mature neurons, glia, or muscle. The cancer-directed immune responses initiated by those antigens have the potential to target autoantigens in the nervous system. There are two large series, one mentioned in the Archives of Neurology and International Journal of Neurology, that NMO is described as a paraneoplastic phenomena in 31% and 12.2% respectively. In our case, she was treated with IV methylprednisolone course for 5 days and started on azathioprine, and she improved well at the time of the discharge. So conclusion, the longitudinally extensive transverse myelitis with NMO positive has been described as not unusual. In our case, the paraneoplastic myelopathy on the background of CA ovary with NMO positive antibody is very unusual. So, but the paraneoplastic syndrome with aquaporin-4 antibody status has been described, but on the background of CA ovary, to the best of the literature surveyed, this is the second case in India, the first being published by Sachdeva et al. From BJA. And here are our references that we have used.
What are aquaporin sites in the brain?
Sir, aquaporin sites are located in the periependymal region and the brainstem regions, sir. Periventricular region in the ependymal regions and the diencephalon hypothalamic regions. Sir?
Did you do VEP? Did you do VEP in this case?
No, sir. We couldn't get VEP done because that examination vision was completely normal, sir.
So once vision is normal, we don't do VEP?
No, sir. We do VEP to look for any subclinical involvement.
What is the importance of subclinical involvement in this case?
Sir?
How the visual features differs in MS, NMOSD, and MOG?
Sir, in multiple sclerosis, it is a short segment one, sir. Whereas in case of NMOSD, it is bilateral and more than half of the optic nerve length will be involved and more posterior and chiasm will be involved. Whereas in MOG, predominantly is bilateral, anterior will be involved with perineural enhancement.
You can do VEP also in this case.
Yes, sir. Actually, we tried to get VEP, sir, but during this.
Hello. Okay. Sir, can I ask one question?
Yes, sir.
Can we consider it is a paraneoplastic entity? Can we consider the paraneoplastic entity?
Sir, paraneoplastic entity has been described, sir, in many case reports, but with aquaporin-4 antibody positive status is that we have to look for these ones. The associations have been described, but on the carcinoma, still now the CA breast and CA lung and carcinoid and esophageal carcinomas have been described, renal cell carcinoma in various case reports, but on the background of the adenocarcinoma ovary, which is histologically proven.
How
This is
many
a-
days after adenocarcinoma did the neuropathology optica presentation was there?
Sir, approximately 4 to 5 months duration, sir.
Okay. Suppose, can we consider in all cases of NMOSD as a paraneoplastic presentation? Suppose if carcinoma features are not there at the presentation of NMOSD, can we relate, or we need to investigate further if the patient, and in what settings we have to consider paraneoplastic situations?
Sir, usually when they doesn't have any primary malignancy, if they present with a typical clinical picture like NMOSD, so when they present elderly, and it is always better to screen for a cancer in an elderly lady, sir, about 40 to 60 years of age.
Okay. So elderly presentations are more important to rule out rather than the NMO presentation in the younger age group.
Yes, sir.
Maybe the
any atypical between the NMO versus paraneoplastic NMO versus non-paraneoplastic NMO?
Yes,
sir.
MRI.
Hello, sir. Sir, can you repeat the question, sir? Voice is not clear.
Differences between an NMO of non-paraneoplastic and NMO is paraneoplastic.
Yes, sir. Sir, there is no much difference. The presentations are same, but
different.
non-paraneoplastic will be more involvement of quadriplegics, and with optic eye involvement will be more.
No, the MRI features. Is there any relation by the MRI features? Can we differentiate both the things? MRI findings.
MRI findings will be longitudinal extensive transverse myelity with quad edema will be more. Edema will be more in case of the NMOSD rather than paraneoplastic.
Okay. Satish sir?
Yeah.
We can go.
Yeah.
Thank you.
Venkatesh next. Dr. Venkatesh. Venkatesh is there.
Venkatesh, are you ready?
Hello, Venkatesh.
Yes, sir. I am there, sir.
Yeah. Start your session.
Yes, sir, I'm sharing my screen, sir. Yes. Is my screen visible, sir?
Yes. Start.
Okay, sir. Good morning, everyone. Respected delegates and panelists, thanks for the opportunity. I am Dr. Venkatesh Mitvalli from final year neurology resident from Andhra Medical College. Today I am presenting a typical presentation of pharyngocervical brachial variant of GBS with SARS-CoV-2 antibodies. Coming to the introduction, as we all know that SARS-CoV-2 causing coronavirus 2019 infection has spread globally with an increasing number of reported cases of critical ill patients with neurological complications. And the neurological complications of COVID-19 range from headache and anosmia to encephalopathy, encephalitis, acute disseminated encephalomyelitis, seizures, and both hemorrhagic and ischemic strokes, and in the peripheral nervous system, myopathies and myositis and Guillain-Barré syndrome. This PCB variant of GBS is a rare localized variant of GBS. It is approximately 3% of the total GBS cases. And usually the clinical features include the oropharyngeal, neck and arm weakness associated with arm areflexia. Usually the lower limb reflexes, there is no lower limb weakness. Here we are reporting, as far as my knowledge, this is the first case of a typical presentation of PCB variant of GBS in India. One case was reported in the Neurology India in the American Academy of Neurology. Here the case report, 35-year-old woman with no prior history of fever, presented with insidious onset, gradually progressive weakness of cervical, bulbar and bilateral facial. The weakness was progressed for 1 month, but the presentation was late to our department. It came at 2 months, and the duration, 2 months duration, along with the asymmetrical weakness of both upper limbs, that is right more than left, of 1.5 months duration. On neurological examination, the patient was alert and oriented and showed dysphonia, dysphagia, and bilateral LMN facial palsy, weakness of neck flexors, and also asymmetrical weakness of proximal and distal muscles of the upper limb. The right side MRC grading is 2/5 and the left side it is 4/5 with diffuse hypotonia. And the strength is normal in lower limbs. There was diffuse hyporeflexia in all the 4 limbs. Here the NCS showed the absent snaps with decreased motor nerve conduction velocities and increased temporal latencies in both upper and lower limbs. CSF examination shows the albinocytological dissociation, and MRI brain and C-spine are normal. The serum ANA is negative, and even the serum ganglioside antibodies are negative. The serum shows the positive SARS-CoV-2 antibodies. The titers are very high, that is 55.25. And here the patient was given the corticosteroids and IV immunoglobulins, and the patient showed mild to moderate improvement. So here the MRI brain and also this MRI cervical spine, which are normal, did not show any significant abnormality. Here the test for the SARS-CoV-2 COVID-19 antibody, it is positive and the titers are very high, 55.25. And as I already mentioned, the ganglioside antibodies are negative. Even the ANA and vasculitis profiles are negative. This NCS report shows the complete snaps are absent, and also in the motor nerve conduction velocities, there is a normal CMAP amplitude in the bilateral median nerves, and there is increased latencies, and the velocities are decreased, and F waves are absent in the median nerves, and also it is prolonged in the common peroneal nerve. So it is suggestive of the sensory motor demyelinating neuropathy consistent with Guillain-Barré syndrome. Here this patient showing the asymmetrical weakness. There is a gross asymmetry between the right and left limbs. When she presented, the power is almost 1/5. And after the IVIG treatment course of corticosteroids and IVIG, the power was improved to 3/5. So coming to the discussion, GBS associated with COVID-19 infection has been reported in more than 50 cases. It includes AADP, Aman variant, Miller-Fisher variant, polyneuritis cranialis, PCB variant. PCB variant was not reported in India. And almost 50% of all these patients require mechanical ventilation, and 10% of them even died. But although excellent recovery after therapy is reported in many of these cases. So the clinical course in our patient is atypical with asymmetrical upper limb weakness and bulbar involvement, and respond moderate to the corticosteroids and IV immunoglobulins. So in conclusion, our case adds to the literature that rare neurological manifestations are possible during this COVID-19 infection, and PCB variant of GBS seems more severe and rare than other etiologies. But more data is needed to confirm the pathological link between this COVID-19 and GBS, to explain the occurrence of relatively higher percentage of axonal forms, and to clarify the prognosis of these cases. And the pitfalls in our study was, in our case, was the patient came late after the weakness was stabilized. She came late, and also the atypical presentation and more similar case studies or case reports are needed to confirm this COVID-19 pathology to this PCB variant, connection to this PCB variant.
Good presentation.
Thank you, sir.
How did you rule out myasthenia in this patient, Venkatesh?
Sir, sorry to mention, sir, in this patient already RNS was also done, sir.
Yeah, that you have to mention. RNS is negative.
Yes, sir. RNS was negative, sir.
One more question, Venkatesh.
Yes, sir.
Does that 2 months delay is there, no, from the presentation to the
Yes,
your seeing the
Yes,
case?
yes, sir. Presentation to the hospital, yes, sir. She came after 2 months duration.
In between, she can catch up a COVID infection, no?
So you have done code test.
You done COVID antibodies?
Yes, sir. We have done the antibodies, sir, but we did not done the RT-PCR, sir. Yes, sir.
Yeah. And in between the after the onset and before going to the hospital, she might develop the infection, no?
Infection, yes, sir.
Venkatesh, what specific anti-ganglioside antibodies have you done for PCB variant?
Sir, PCB variant GT have shown, sir, GT1A. It was
anti-GT1A antibodies.
Yes, sir.
What type of virus? COVID virus? What type of virus?
Sir?
What type of virus? COVID virus?
Sir, RNA virus, sir.
Single strand or double strand?
Single strand RNA virus, sir.
What are the proteins?
Sir?
What type of proteins you get in COVID-19, in coronavirus?
Spike.
Your membrane protein, like that, you get some proteins. Just to let know how far you read the microbiology of coronavirus.
Spike protein.
Yes, spike protein, envelope protein, membrane protein. Okay.
Okay, Venkatesh.
Okay, sir. Thank you, sir.
Right, Venkatesh.
Okay, thank you, sir.
Gautam, we can go next.
Yes, sir. We can go, sir, next.
Yeah. Vishal, next. Are you ready?
Yes, sir. Yes, sir. I'm ready.
Yeah. Please start.
1 second, sir.
One request, I request all the presenters to complete on time because we are running 10 minutes late. We should be able to start the oration by 9:30.
Sir, is my screen visible, sir?
Yes.
Sir, I'm Dr. Yes, sir.
Yeah.
I'm Dr. Vishal. I'm final year neurology resident from Nizam's Institute. Today, my presentation is PET findings in autoimmune encephalitis. Autoimmune encephalitis is increasingly recognized as a potential treatable cause of encephalitic syndrome. PET scan is used in these patients to look for metabolic changes and to detect any occult primary malignant focus as well as to consider paraneoplastic conditions. These findings are variable with different types of autoimmune encephalitis. This is the consensus criteria in 2016 for autoimmune possible encephalitis. All three should be there. That is subacute presentation within less than 3 months of working memory deficits and altered mental status or psychiatric symptoms. And at least one of the following has to be there, like new focal findings of focal CNS findings, seizures not explained by previous seizure disorder, CSF pleocytosis, and MRI features of encephalitis. And we should exclude all other causes. Aim of this study was to study the frequency and range of PET abnormalities in seropositive and seronegative autoimmune encephalitis and to correlate serological antibodies, CSF inflammatory, EEG features, and MRI findings, and to find out paraneoplastic type in a whole body PET scan. Study design was observational, retrospective, and prospective case series. Is carried out in Nizam's Institute of Medical Science and Neurology Department. Duration of study was 2 years and sample size was 30 patients. Here we retrospectively reviewed and collected prospectively the case records of autoimmune encephalitis patients admitted in Neurology Department between 2018 and 20. Autoimmune encephalitis was diagnosed on the basis of clinical history, examination, investigation, and exclusion of other causes. Investigation included MRI, PET, CSF analysis, EEG, serological studies, and malignancy workup, apart from the routine blood chemistries. We followed these patients prospectively at regular intervals. Inclusion criteria: all patients aged more than 5 years with suspected encephalitis, fulfilling the consensus criteria for definition of autoimmune encephalitis. Those who are not giving consent and proven TB or bacterial meningoencephalitis and known case of cerebral metastasis and proven metabolic causes of encephalitis are excluded. Statistical analysis: categorical variable are presented as number and percentage, while numerical variables are presented as mean, median, and as appropriate. And data was also represented using appropriate diagrams, bar diagram like pie diagram. Data was represented as numbers and mean as appropriate. Coming to results, the 30 of autoimmune encephalitis patients were identified. Females were 16, males were 14. Sex ratio being 0.9:1. Mean age was ranging from 6 to 72 years and 35 years. 19 patients had seizures as the predominant manifestation. 12 had movement disorders. 11 has behavioral abnormalities. This is the male is to female sex distribution, and seizures are the main predominant signs. Later being followed by involuntary movements and abnormal behavior changes. Out of the 30 patients, 13 were seropositive and 17 were seronegative. And AMPA was positive in 3, TPO antibodies were positive in 5, and 1 in GAD positive, and remaining are NMDA positive in 5 patients. And MRI was abnormal in 11 patients and normal in 19 patients. Greater than 2 areas of hyperintensities are noted in MRI and in 11 patients, and majority of these are temporal and parietal hyperintensities. Coming to PET findings, cortex being most involved, followed by brainstem and thalamus and basal ganglia coming in the next order. Both hypermetabolism and hypometabolism have been noted, but hypo is the most common as compared to other studies and observed in 19 of the 30 patients, hyper in 17 patients, and both combination in 4 patients. This is a case. He is a 60 years male patient present with subacute onset within 1.5 months. He presented with short-term memory loss with behavioral changes, and we have excluded other causes. And CSF analysis showed normal cells with increased protein. This patient showed a medial temporal hyperintensity on left side in MRI, and we have done PET where it showed bilateral left more than right medial temporal hypermetabolism. This is another case, a 52-year male presented with fever followed by behavioral disturbance in 1 month. On examination, there were no deficit except for language disturbance, and MRI showed bilateral temporal orbitofrontal thalamic hyperintensities. CSF showed increased protein with normal glucose and nil cells. His PET scan shown temporal right more than left, and temporal hypometabolism, and also parental hypometabolism. So a major limitation of this study is that is retrospective, and it included all the patients meeting the criteria who underwent PET at a single tertiary center, leading to some selection bias. The sample size being small, and not all patients underwent CSF antibodies testing, which may be more sensitive. So we may underestimate the number of seropositive patients. However, there is no difference between brain region metabolism between the seropositive and seronegative groups. Future prospective studies may further clarify the role of PET in diagnosis and monitoring autoimmune encephalitis in general and specific antibody syndrome in particular. Conclusion: PET was abnormal more than MRI in autoimmune encephalitis, with brain cortex region hypometabolism being the most frequently observed. And most importantly, in seronegative autoimmune encephalitis with unremarkable MRI, FDG PET showed typical findings of autoimmune encephalitis, and it can be kept as an early biomarker for earlier treatment and improved outcome. Thank you.
Okay, Dr. Vishal. What is the sensitivity and specificity of PET in AI? Hello. Yeah, Vishal?
Sir.
Yeah. Sensitivity and specificity of PET in autoimmune encephalitis?
Sir, it can be used as early biomarker, but when we have to correlate with clinically with other findings, sir. I'm getting disturbance.
Yeah, if PET negative also features of autoimmune encephalitis, no? Hello?
Yes, sir. Yes, sir. Yes, sir.
Yeah. And
based on the
specificity, how we have to, in what situation we have to proceed?
Sir, if this predominantly if they are seronegative and MRI are inconclusive, but clinical criteria is going more favor with autoimmune encephalitis, PET can add an information so that treatment cannot be delayed, and we can.
So can we?
Sir, I'm getting very much distance.
Yeah. Sir, please unmute. Is that?
Vishal?
Sir.
Sir was asking about the sensitivity and specificity of the test.
Sir, and means
it gives in percentage. No, sensitivity and specificity will be given in percentage. Okay, no problem.
So why all patients not underwent CSF antibody test?
Sir, CSF antibody was not done in all, sir. Only few patients we have done. Because the cost being high and delay in treatment waiting for the antibodies.
Did you take institutional ethics committee approval for this?
Yes, sir. Yes,
then there is no question of cost coming in the way. You are presenting the paper. You would have done on your own.
Okay.
Sir, we didn't wait for.
Okay. So PET will be more useful in paraneoplastic autoimmune rather than paraneoplastic or cancer-associated autoimmune versus non-cancer-associated autoimmune encephalitis?
Yes, sir. And to rule out paraneoplastic, PET will be very helpful in like intracellular network.
It will be more useful in this cancer-associated IA versus non-cancer.
Yes, sir. Yes, sir.
Okay, right. Okay. So next, Dr. Satish. Dr. Satish is ready here?
Yes, sir. I'm ready, sir.
Yeah, start.
Can you hear me, sir?
Yes.
Yeah.
Yes. Go ahead, Satish.
Can you see my screen, sir?
Yes.
Good morning, sir. I am Dr. Satish, final year senior resident, Department of Neurology, SIMS Tirupati. My study was a prospective open-label study of clinical profile and outcome of patients with acute ischemic stroke receiving intravenous thrombolysis, both alteplase or tenecteplase. Acute ischemic stroke is the leading cause of morbidity and mortality worldwide and is responsible for 3 million deaths in developing countries. IV thrombolysis and more specifically mechanical thrombectomy in large vessel occlusions will favorably influence the outcome in acute stroke patients. Here we discuss the clinical characteristics of stroke patients who underwent IV thrombolysis with a focus on window period, door to needle time, and the complications associated with thrombolysis, post-thrombolysis, and primary outcome was measured at by NIH's at admission and discharge, the comparison between NIHS score, and the secondary outcome was comparison of MRS at admission time and then 3 months of follow-up. Study design is a prospective open label study, and study population was 1.5 year from 2019 to the October 2020, and regulatory approvals has been taken from the SWIMS ethics committee, and also written informed consent has been obtained from all study participants. Inclusion criteria: patient presenting with window period of 4.5 hours was included in inclusion criteria. Exclusion criteria: major intracranial hemorrhage or subarachnoid hemorrhage and coagulopathy INR more than 1.57 were excluded, and other standard contraindication of IV thrombolysis like neurosurgery, spine surgery, brain surgery, or other malignancy or GI surgeries are also excluded. And the data analysis, clinical and demographic characteristics were analyzed: window period, O2 needle time, NIHS score, and MRS score, and complications post thrombolysis were measured. And the primary outcome was difference in NIHS score at admission and discharge, and analyzed using student t-test. And secondary outcome was change in MRS score at 3 months when compared to the initial MRS score admission, and p were less than 0.05 was considered statistically significant. Results: these are the clinical characteristic of patient cohort, and the mean age of presentation was 56.2 years, and the male outnumbered the females, and 55 are male and 19 are females. Risk factors: hypertension, diabetic are the major risk factors found in this study, followed by alcoholism and cardiac diseases constituting around 25% of cases. TOST classification: major artery occlusion, large artery occlusion was seen in 54 patients, cardioembolic in 13 patients, small vessel in 20, and other causes like 5 or 6 was other determined etiologies. Stroke territory: anterior circulation involved in 73% of cases, posterior circulation 10%, and Lachner syndrome in 16% of cases. NHS at admission, more number of patients, around 67%, are presented with moderate stroke at 5 to 15 NIHS score, and moderate to severe, around 10% of cases are present in moderate to severe stroke. And the average window period measured was 164.85 minutes, 85 minutes, and the interquartile range was 117 to 240, and the average door to needle time was mean 74 minutes, and the drug administered was altiplase in 29 patients and tenecteplase in 45 patients. And the complication symptomatic ICH was seen in one patient, that is his NIHS score was changed was 4, NIHS score was increased by 4. Asymptomatic ICH was seen in 5 patients, and a decompressive craniectomy, 2 patients went for decompression, and 5 patients expired due to 2 patients are due to the anaphylactic reaction to the stenectoplase, and one for post thrombolysis, and remaining 2 patients in the follow-up they expired due to secondary infections, and mean duration of hospital stay was 9.6 days. Here the NIHS score comparison at admission and discharge, more number of patients, around 40 patients were present in 5 to 10 NIHS score, but at the time of discharge, NIHS score was 31 patients presented, had a MRS score of less than 5 at the time of discharge. So this was the difference between NIHS score difference admission and discharge, whereas MRS comparison at admission 3 months follow-up. At admission, more patients were dependent or wheelchair bound, having MRS score of 3 or 4. Around 44 patients were presented with MRS of 3 or 4, whereas at the 3 months follow-up, patients were 65 patients, 60 patients were presented with MRS of 0, 1, or 2 with functional independence. And primary outcome, NIHS score decrease, favorable outcome was NIHS score decreased by 4 at the time of admission and discharge. 38 patients showed favorable outcome, and 32 patients showed unfavorable outcome with statistical significant p-value. Whereas difference between the NIHS score at admission and discharge between altiplase and tenecteplase, 17 patients out of 29 showed favorable outcome in altiplase group, whereas 20 patients out of 45 showed a favorable outcome in tenecteplase group, but it is not statistically significant between altiplase and tenecteplase group. The secondary outcome, improvement MRS score from admission to 3 months, 47 patients showed favorable outcome, 27 patients showed unfavorable outcome, that is functional independent, and the p-value was statistically significant. And the secondary outcome between alteplase and tenecteplase, 20 patients showed favorable outcome and 27 patients tenecteplase showed favorable outcome. But there is no statistically significant between alteplase and tenecteplase group in terms of secondary outcome. Discussion, real life clinical scenario of stroke thrombolysis in a resource poor setting for mechanical thrombectomy revealed statistically significant favorable outcome for primary and secondary outcome in cases who underwent IV thrombolysis. No difference in primary outcome between alteplase and tenecteplase group. No difference secondary outcome between alteplase and tenecteplase group. This was a comparison with other studies. Our present study sample size was 74 and the average window period was 164 minutes. And other studies showed around 130 to 190 window period. And the door to needle time at our institute was 74 minutes when compared to the other studies like Indian studies like 66 minutes and 78 minutes in Padmavi et al. And 90 minutes in other studies. And primary outcome was 54% improvement was there in NHS score, that is primary outcome in our study, whereas a few other studies were 65%. And second outcome was seen around 64%, that is MRS improvement, whereas other studies 72 and 74% improvement was seen in a few other studies. These are my other references.
Okay, thank you, Dr. Satish. Why more alteplase patients are there in your disease? Because of free availability or something more easily administrable drug, or why you have more alteplase than tenecteplase rather than alteplase?
Sir, cost factor, sir. Alteplase and tenecteplase cost factor.
Okay.
And patient, main thing was the cost factor only, sir. When we counseled for IV thrombolysis, when we give for two options, alteplase, tenecteplase.
Okay.
Cost, we explained them, but they opted for more tenecteplase.
Okay.
Are you thrombolizing for NHS less than 4 also?
Yes, sir. Because two patients who is a TTD employees presented with right hand weakness, hand grip weakness, because of his occupational limitation due to this stroke, we thrombolized two patients, sir. Only right hand weakness. So NHS score less than 4 also we thrombolized, sir.
Latest criteria, latest guidelines says. Any latest guidelines? What are the latest guidelines saying about NHS 4, less than 4?
Yes, sir. We can thrombolize in minor stroke patients also, sir. If it is functional disabling the patient, if that deficit, neurological deficit.
Okay. Right. Dr. Gopi sir, any question? Okay, Dr. Satish. Okay, this is good study. Right. So next we'll go, because of time limitation, can we go for the next topic?
Yes, sir.
Dr. Harita, are you ready?
Yes, sir, I'm ready.
Yeah. Please start.
Can you see my screen, sir?
Yes.
Good morning, everyone. I'm Dr. Harita from NIMS. I'm going to present about long-term outcome and efficacy of immunosuppression in aquaporin 4 positive neuromyelitis optica spectrum disorder, a single-center study from South India. Introduction: NMO was first described by Devick and Gault at the end of 19th century. The presence of aquaporin 4 antibodies in serum was first discovered by Dr. Lennon and colleagues. The morbidity due to disease is attack-related in NMOSD. Hence, it is important to treat the acute attacks and prevent secondary attacks in NMOSD with long-term immunosuppression. Aims and objectives. Our main objective is to study the long-term effect of immunosuppression on disease course in patients suffering from aquaporin NMOSD by quantifying the EDS score of the patients at the time of initial presentation and during the subsequent follow-up, by calculating the annualized relapse rates to know the effectiveness of long-term immunosuppression on the outcome of the disease, and to compare the effectiveness of various immunosuppressive drugs by calculating the differences in ARR before and after treatment, and also by calculating the time to first relapse of the individual immunosuppressive agent. The study period was 2 years and it is retrospective observational study. Institutional ethics committee approval was taken. Inclusion criteria include all patients who are fitting into the criteria of NMOSD according to 2015 criteria of International Panel for NMO Diagnosis and who are aquaporin 4 positive. Patients fitting into above criteria who were on minimum of 2 years of follow-up on long-term immunosuppressive agents like methotrexate, azathioprine, MMF, and rituximab. Exclusion criteria: patients who did not complete 2 years of treatment with steroid-sparing immunosuppressive agents due to any reasons like drug-related adverse effects, non-compliance with the medications, financial constraints, and secondary infections. Patients who had not given consent to the study, patients with proven other CNS inflammatory or demyelinating disorders like MS or sarcoidosis. Statistical analysis: categorical variables were presented as numbers and percentages, while numerical or continuous variables were presented as mean or median. For the assessment of normal distribution, Shapiro-Wilk test was used. Comparative analysis for normal distributed continuous independent variables was done using one-way ANOVA test, and for dependent variables using sample paired t-test. Pre and post treatment ARS were calculated using Wilcoxon sign rank test. EDSs at the onset of the disease and at last follow-up were compared using paired sample t-test. Statistical analysis was done using SPSS version 23. The total number of patients were 52, and out of which females were predominant, 46, and the ratio is 8:1. Male to female ratio was maintained across all the age groups, and no males were present beyond 40 years of age. Mean ARR of males is more than that of females. Coming to demographic data, the mean age of the study population is 31 years, and females were predominant. Duration of the disease is 60 months. The onset of disease to the start of long-term immunosuppression is 6 months. The number of attacks prior to the diagnosis of NMOSD were 2. Type of attacks: more number of patients had transverse myelitis, about 36%, optic neuritis in 21%, area prostoма syndrome in 11%, cerebral syndrome in 5%. In the combination, majority of the patients had transverse myelitis plus optic neuritis, and they are of 38%. The EDSs at last follow-up, majority of the patients had EDSs of 1.5 to 5.5. The median number of attacks were 3. The number of patients who took azathioprine were 16, MMF were 11, rituximab were 10, methotrexate it is 1. The time to first relapse, there were no relapses after second year in MMF and also in rituximab treatment treated patients. Whereas we can see there are more number of relapses in the azathioprine group. Pre and post treatment ARRs, the pre-treatment ARR of azathioprine is 2, post treatment is 0.16. For MMF, pre is 2, post is 0. For rituximab, pre is 1, post is 0. Methotrexate, pre is 0.67, post treatment ARR is 0.36. The EDSs at the onset and at follow-up: azathioprine EDSs at the onset of disease is 6.25. At last follow-up, it is 4. For MMF, at the onset of disease, it is 6. At last follow-up, it is 3. Rituximab, it is 5.5, and at last follow-up, it is 3. Methotrexate, at the onset of disease, it is 4, and at last follow-up, it is 3. And all these are statistically significant. The change in treatment causes include majority of the cases are due to drug-related adverse effects. And next, financial constraints. One patient was shifted from MMF to azathioprine because of pregnancy. Complications according to long-term drug treatment: majority of the complications were seen with azathioprine group, and they include hepatitis and leukopenias. In mycophenolate mofetil group, diarrhea was seen. In rituximab, apart from UTIs, no other adverse effects were seen. Discussion: time to first relapse in azathioprine group was more in the first year. It is about 29%. Azathioprine failure was seen in 52% of the patients, which is similar to several other studies on azathioprine like Mealy et al. And Elson et al. 53% of the patients on MMF has no relapses, and 18% relapses in the first and second year, and 11% in third year. The failure rate in our study is slightly higher compared to other studies like Husa et al. And had failure rate, which had a failure rate of about 40%. There were no relapses in the rituximab group, which is better than many studies, which had failure rate of varying from 0 to 40%. On methotrexate group, 25% relapsed in the first year, second year, and third year, and none relapsed in 25% of the patients. This is very less compared. This is less compared to the other study by Kitley et al. The pre and post treatment analyzed relapse rate decreased significantly with all the three drugs. This is similar to other studies. Median EDSS in azathioprine pre and post treatment group decreased from 6.25 to 3.74, and in all other groups, this is similar to study by Jiang et al. On comparison of three drugs, the probability of being relapse-free is higher with rituximab group followed by azathioprine and then MMF, with a significant p-value of 0.018. All the previous studies showed that rituximab is superior to all the others with fewer relapse rates. Conclusion: females were more in our group. No males were present in older age group. Most presentation was that of transverse myelitis. Early diagnosis and treatment initiation is necessary for lesser disability. ARR and EDSS significantly decreased with azathioprine, MMF, and rituximab. Probability of being relapse-free is higher with rituximab, which is followed by azathioprine and then by MMF. Drug-related adverse effects were high with azathioprine, with more probability of drug withdrawal. I thank all my professors. Thank you.
Okay, thank you, Dr. Harita. It's a good study actually. So one good fact is rituximab, actually antibodies are more prone for relapse when they stop. All autoimmune diseases are more prevalent when once you stop, more frequent rather than in the preceding the drug. But in your study, rituximab is more useful than other drugs. So
Yes,
how many doses of rituximab you have given?
11 patients, sir.
I don't know. How many? 2 doses? How many doses you have given?
We have given every 6 months, sir.
6 months. Okay.
Yes,
so at the end of that 2 years period, that means you have given 4 doses.
Yes, sir.
2 year.
Yes, sir.
So how many days after the last dose you have followed those patients? Last dose of that drug, and how many days follow up after that last dose?
Patients are still in follow-up, sir. Few patients are still in follow-up. They have been taking rituximab.
Okay.
They'll be coming to us for every 6 months.
Okay. So sustained effect we need to see actually.
Yes, sir.
Okay, that's a good. Okay. Gautam?
Yes, sir.
Can we go because time is...
Yes, sir. We can go.
Thank you, Dr. Harita. So next, Dr. Hemant. Dr. Hemant is ready here?
Ready, sir.
Hemant?
Sir.
You're not audible, Hemant?
Hemant?
Sir. Am I audible, sir?
For me, you are audible. For Satish, sir?
Yeah. Yes.
Sir.
Hemant?
Shall I start, sir?
Yeah, you can.
Good morning, everyone. I'm Dr. Hemant from GJ Guntur. I'm going to present 2 case series. It is about adolescent or adult onset leukodystrophy due to methylene tetrahydrofolate reductase deficiency, treatable cause. Coming to introduction, methylene tetrahydrofolate reductase deficiency has an autosomal recessive inheritance pattern and is the most common inherited disorder of folate metabolism. Methylene tetrahydrofolate catalyzes the NADPH dependent reduction of 5,10 methylene tetrahydrofolate to 5-methyl tetrahydrofolate, which in turn is required for the conversion of homocysteine to methionine, which is required for the formation of phospholipid of neuron. Methionine help in formation of myelin sheath. In the absence of methionine, there is myelin degradation. Biochemically, there are elevated plasma homocysteine, homocystinuria, and low methionine levels. 5-10-methylene tetrahydrofolate reductase deficiency is a genetic disorder that can occur at any age and can be easily detected by increased homocystinemia. In adult onset forms, the clinical picture is often complex with association of various neurological features and thrombosis. Adult onset MTHFR deficiency may manifest with a combination of progressive spastic paraparesis and polyneuropathy, variable behavioral changes, cognitive impairment, psychosis, and seizures. Brain atrophy and white matter disease are present in almost all cases. So we present 2 cases of leukodystrophy presenting as paraparesis. Case 1 is of a 17-year-old male born out of consanguineous parentage, was brought with complaints of difficulty in walking from 10 years of age. He had difficulty in the form of stiffness of both lower limbs, associated with difficulty in wearing chappals, difficulty in getting up and down the stairs, difficulty in getting up from squatting position. There is no history of weakness of upper limbs, no history of cranial nerve or bowel and bladder involvement or sensory symptoms, had a history of cerebral venous sinus thrombosis. On examination, his cranial nerves are intact, spasticity of both lower limbs, with power of 3/5 in lower limbs and 5/5 in upper limbs, with exaggerated deep tendon reflexes, bilateral Babinski and spastic gait. And all routine blood investigations are normal. MRI scan of spine is normal. CSF fluid analysis is normal. An MRI brain showed T2 and flight hyperintensities in bilateral symmetrical frontal and parietal regions, such as leukodystrophy. And as he had got a CSVT, we sent for serum homocysteine levels. They are elevated. And we sent for a genetic profile for leukodystrophy, which came positive for MTHFR deficiency. Is the picture of the patient showing T2 and flare hyperintensities in frontal and parietal white matter areas, which is suggestive of leukodystrophy. And his MRI spine was normal. And his homocysteine levels are more than 50. This is the genetic report showing homocystinuria due to methylene tetrahydrofolate deficiency. The second case, a 20-year male patient born out of consanguineous parentage, presenting with complaints of weakness of both lower limbs since 1 month, without bowel and bladder involvement, without sensory symptoms, without cranial nerve and upper limb weakness, and normal cognition without any family history. Examinations, there is spasticity of both lower limbs with exaggerated reflexes and ankylosing with bilateral Babinski. And all the routine blood investigations are normal. MRI spine was normal, NCS is normal, and CSF fluid analysis is normal. MR brain showed like similar like the last case, like symmetrical white matter hyperintensities in bilateral deep periventricular and frontoparental white matter, suggestion of leukodystrophy, and his serum homocysteine levels was also elevated, and the genetic profile came positive for homocystinuria due to methylene tetrahydrofolate deficiency. Is the MRI picture of this second case showing the hyperintensities in frontoparietal white matters. Is the genetic profile report showing homocystinuria due to methylene tetrahydrofolate deficiency of autosomal recessive pattern. So both the patients were treated with betine, tablet betine, tablet homine, and given supportive therapy, and they are symptomatically improved. So come to conclusion, since methylene tetrahydrofolate deficiency is a potential treatable disease, early diagnosis is crucial, and betine treatment should be started as early as possible. So it is therefore imperative for clinicians to be aware of the clinical patterns of early and late onset forms of the disease, and one should consider this treatable condition of spastic paraplegia. Thank you.
Okay, that was a nice presentation. Thank you.
Okay.
I think we can conclude the session now.
Yes, sir. Yes, sir. We can conclude the session.
I thank all the presenters, and then thank everyone for giving me this opportunity.
So thank you so much, sir. We can now move on to Hall 3 for the rest of the sessions till 2 o'clock, sir. Next we have the Muralidhar Rao oration in the Hall 3.
Neurology and neurosurgery session. Thank you, everyone.
Welcome back to Hall 2. We now start the lunch on symposium. Now we have the speaker, Dr. K. Rajesh. He'll be speaking on thrombolysis in acute stroke, tenecteplase versus alteplase. For this session, I would like to invite Dr. Asutosh Prasad sir and Dr. Sirisha madam to chair the session. Over to you, sir.
Thank you, Dr. Saini Nirma. We welcome Dr. Rajesh, and he is the only live presenter in this entire two-day conference. The rest of all were in virtual mode. He is the only one presenting on stage. So he is going to discuss the pros and cons and debate between alteplase and tenecteplase in stroke thrombolysis. Dr. Sirisha will introduce Dr. Rajesh. Dr. Sirisha.
Yeah, good afternoon. It's a privilege to have Rajesh sir to be talking on acute thrombolysis, the debate between alteplase and tenecteplase. Dr. Rajesh was my senior in NIMS and he had exceptional interest in stroke and he was very approachable to simplify all the complicated stroke guidelines. So over to Dr. Rajesh.
Good afternoon. And first of all, I thank Dr. Raju sir for providing me opportunity. And thank you, Sirisha. And today we'll discuss about thrombolysis in acute stroke, alteplase versus tenecteplase. The treatment of acute ischemic stroke is mainly divided into medical support, IV thrombolysis, endovascular techniques, antithrombotic treatment, neuroprotection, and neurorehabilitation. Out of these, today we'll discuss about IV thrombolysis. The stroke consists of ischemic core, which is the brain tissue that is destined to die.
Is surrounded by penumbra, which is a salvageable brain area. The reperfusion offers the potential to reduce the extent of ischemic injury. The types of thrombolytic agents, which are
which are first generation, which are urokinase and streptokinase, which are a failure in stroke thrombolysis, followed by a second generation thrombolytic agent, which is alteplase, followed by third generation thrombolytic agent tenecteplase, which are currently approved in stroke thrombolysis. The world before NINDS, there is no effective treatment of stroke, and in after NINDS trial, there is approval of stroke treatment less than 3 hours. After ECAS 3 trial, up to 4.5 hours, stroke thrombolysis were approved, in which India is also a part. Despite of this, only 1% of the strokes get thrombolized because of lack of awareness among the public, delayed referral, and financial constraints, and especially in our setting, patients and attendants' attitude also contribute. The importance of thrombolytic therapy in stroke is underestimated. So the numbers needed to treat tells the story. In stroke thrombolysis, NNT is 6. The lower the number, the effective the treatment. The much boasted acute cardiac revascularization, primary PTCA, the number is 18. The cardiac thrombolysis, the number is 33. Compared to stroke thrombolysis, which is very, very effective, 6. And aspirin for stroke, the number needed is 100. In stroke, time lost is brain lost. What took you a lifetime to learn can be lost in few minutes. With a stroke, time lost is brain lost. So we have to be quicker than stroke. So time is brain. Per hour of stroke, delay in treatment, there is accelerated aging by 3.6 years. So thrombolysis effects are time dependent. The slope is not dependent upon age of the patient or severity of the stroke. Rather, speed is the essence. The the earlier the thrombolysis, the better the results. If you see the first 90 minutes, the odds ratio is 2.55 versus the now NNT is 4 to 5. In the first 3 hours, it is 1.6 odds ratio and NNT is 9. And it reduces and it's almost equal to the baseline after 4.5 hours. And the earlier the patient is in the hospital, the more time for IV thrombolysis is left. But the sooner the thrombolysis initiated, greater the benefit. The concept of if patient arrives early, the doctor has more time is totally unacceptable. That means if the door to needle time, if you reduce the door to needle time, even though patient, the time pre-hospital time, if it is delayed, there will be benefit. So coming to the selection criteria for intravenous thrombolysis, stroke by clinical assessment, persistent deficit of NHS more than 4, and CT scan showing no hemorrhage, and treatment within 4.5 hours. If the thrombolysis increase the chance of favorable outcome. In all trials of TPA within 3 hours of symptom onset, NHS score decreasing less than 1, Barthel index, modified ranking scale, Glasgow outcome scale, all show there is favorable outcome at 90 days, a relative increase in the scores. The net benefit of thrombolysis can be told like for every 100 patients, 13 more patients will achieve independence at 3 months. Coming to the safety profile of TPA, ECOS-3 study showed that mortality by time interval after 90 days, there is no increase in mortality in TPA patients. There is no increase in risk of mortality. But there is increased risk of symptomatic ICH for patients treated up to 4.5 hours with TPA. But the overall risk of ICH or mortality rate is low and similar in both patient groups. And SITSMO study is the study where the patients of thrombolysis outside the trial world, that is real world evidence. The real world evidence also to show that the new thrombolytic centers are similar in efficacy of experienced centers. And experienced centers and real world evidence show that it is safe as effective, and safety is also the 1.7%, 1.6% in the SITSMOST trial compared to 6% of ICH in the NINS trial. The SITS new Asian population, that is non-European Union world, it's also show that it is comparable. Asian population showed significantly better functional outcome than European population, and safety is similar both Asian and European population. RTPA has been consistent in its efficacy and safety across all trials and global registries. If you take NINS trial, ECOS-3 or SITS-MOST, all three trials show efficacy of MRS at 3 months. There is improved outcome, as well as the lesser symptomatic ICH rates observed with ECOS-3 and SITS-MOST compared to NINS trial of 6.4% in the NINS trial compared with 2.4 and 1.7 in the ECOS-3 and SITS-MOST trial. Coming to the tenecteplase, why tenecteplase? Tenecteplase has some pharmacological advantage over alteplase. It has higher fibrin specificity, more thrombolytic potency. It has plasminogen activator inhibitor resistance. It has lesser fibrinogen depletion potential, and platelet-rich thrombus activity is more. So it has more pharmacological advantage. Whether it is clinically relevant or not, we will see. The efficacy of and safety of tenecteplase was tried in 2 trials, that is one open label study, randomized study, 2 doses of tenecteplase, 0.1 and 0.2 mg per kg were compared, and study 2, 0.2 mg compared with NINS trial. The endpoints is primary endpoint of improvement of more than 8 points or a score of 0 or NIHS, that is major neurological improvement at 24 hours, or a secondary outcome of neurological improvement assessed by NIHS score or modified Rankin score on day 7, 30 and 90 days, and safety assessment by symptomatic ICH within 36 hours or asymptomatic ICH after 48 hours after treatment. The results show that MRS at 3 months, 0 to 1, that is it is significant, and also safety symptomatic ICH at 36 hours and mortality at 3 months also lower in TPA group compared to a NINS trial. After that, evidence that tenecteplase is non-inferior to alteplase for acute ischemic stroke, a meta-analysis of 5 randomized trials. There are almost 1,600 patients were enrolled from 5 trials. Across all trials, for the primary endpoint of crude cumulative rate of disability free, that is MRS 0 to 1 at 3 months, was tenecteplase of 57.9 versus alteplase of 55 point. Similar results for additional efficacy endpoints of functional independence, that is MRS score of 0 to 2. That means tenecteplase is non-inferior to alteplase. These trials are tenecteplase S2B, Australian tenecteplase trial, ATTEST trial, NORTEST trial, and extent 1-year tenecteplase trial. And this is the forest plot showing tenecteplase versus alteplase. The primary outcome of freedom from disability, that is MRS 0 to 1, in all the groups, whether it is 0.1 mg per kg or 0.25 mg per kg or 0.4 mg per kg of tenecteplase. Tenecteplase is not inferior to alteplase. And this is the secondary and outcome, that is functional independence of MRS 0 to 2. Again, in all the doses, tenecteplase is non-inferior to alteplase. Accumulated clinical data provides strong evidence that tenecteplase is non-inferior to alteplase in the treatment of acute stroke, and these findings provides formal support to the recent guidelines of tenecteplase as an alternative to alteplase. Now, a random trial of tenecteplase versus alteplase for acute ischemia. This is the first head-on-head trial of alteplase and tenecteplase. This is a phase 2b trial. They had 75 patients to receive alteplase in the 0.9 mg per kg or tenecteplase of 0.1 or 0.25 mg per kg in less than 6 hours of stroke. The eligibility criteria are perfusion of at least 20% greater than infarct core and CT perfusion imaging at baseline and associated vessel occlusion on CT angiography. The primary endpoints are the perfusion lesion reperfused at 24 hours on perfusion MRI and the extent of clinical improvement at 24 hours assessed on NIHSS. The results show that the alteplase group and tenecteplase 0.1 mg and 0.25 mg show that two tenecteplase groups had greater perfusion, greater reperfusion and clinical improvement at 24 hours than alteplase groups. There were no significant group differences between intracranial bleeding or other adverse side effects. So the higher the dose of tenecteplase, that is 0.25 mg per kg, was superior to the lower doses, that is 0.1 mg, or alteplase for all efficacy outcomes, including the absence of serious disability at 90 days. And tenecteplase is associated with better reperfusion and clinical outcomes than alteplase in stroke patients selected on basis of CT perfusion imaging. But this trial has limitation that very small sample of 75 patients only, and all patients has a CT angio done which shows perfusion diffusion mismatch and vessel occlusion. So to overcome these limitations, a NOR test trial, a phase 3 trial was studied in which 1100 patients were analyzed with the tenecteplase of 0.4 mg per kg versus alteplase of 0.9 mg per kg in acute patients. The primary outcome is 90-day MRS score of 0 to 1, which is achieved in 64% of patients with tenecteplase compared to 63% of alteplase. But in this trial, most of the patients are mild. The almost 70 to 80% of the patients have NIHS score of 0 to 7. The intention to treat, that is primary outcome of MRS at 0 to 1 at 3 months and secondary outcome of symptom ICH of 20 to 48 hours or symptomatic ICH at 20 to 48 hours or major clinical improvement at 24 hours or death within 3 months showed tenecteplase and alteplase has similar efficacy and safety profile. So to study the limitation of this study, that is most of the patients are mild strokes, they have analyzed the NOR test results, that is in the post hoc analysis moderate stroke patients of the NOR test trial, that is NIH score of 6 to 14 and severe stroke patients of NIH more than 15. The favorable outcome at 90 days, symptomatic ICH and mortality after 90 days were assessed. So out of all these, mortality rate at 90 days, tenecteplase group has 26% compared to alteplase group of 9%, which is statistically significant. That shows in patients with moderate stroke, there were no difference between favorable outcome, spontaneous ICH or symptomatic ICH or mortality between tenecteplase and alteplase. But patients with severe stroke, there is no difference in outcomes, frequency of ICH or mortality at 7 days. But all-cause mortality at 90 days was increased in patients with tenecteplase. So rates of favorable outcome and ICH were similar between treatment groups in moderate and severe stroke, but mortality rate at 90 days increased in patients with severe stroke receiving tenecteplase. So there is another trial, Extend 1A. The results came after from tenecteplase head-on with alteplase in 200 patients from Australia and New Zealand. they have received thrombolysis within 4.5 hours of stroke onset and followed by thrombectomy within 6 hours of onset. In this, a patient should have within 4.5 hours of stroke onset thrombolysis and evidence of large vessel occlusion and CT angiography, and undergo IV thrombolysis and endovascular thrombectomy both. Exclusion criteria is patient with severe pre-existing disability of more than MRS3. They have received tenecteplase of 0.25 mg per kg and alteplase 0.9 mg per kg. The primary outcome of reperfusion of more than 50% of the involved territory, which is 22% in the tenecteplase group compared to 10% of the alteplase group. And the secondary outcomes like functional independent outcome and excellent outcome, early neurological improvement and deaths, and also symptomatic ICH, they were assessed for the secondary endpoints. The modified ranking score shows that patient in the tenecteplase group had a median score of 2 compared with 3 in the alteplase group. And also NIHS score at baseline and 72 hours and 24 hours showed tenecteplase is non-inferior to alteplase in restoring perfusion in the territory of proximal cerebral artery occlusion. Overall functional outcome was better with tenecteplase than alteplase, but there was no significant difference in the intracerebral hemorrhage. So in the part 2 of the extend 1 year trial, they have compared with 0.4 mg of 0.4 mg per kg of tenecteplase compared to 0.25 mg per kg. In these patients more than 18 years received thrombolysis within 4.5 hours of stroke and 150 in each group. Primary outcome of TC 2b/3 in the score with normal flow 0, no flow in the 0, 3 normal flow. Secondary outcome of MRS, NIHS, symptomatic ICH, death and angiographic reperfusion were assessed. And these results show that primary efficacy outcome or secondary outcome and safety, the result was there is no difference between 0.4 mg per kg or 0.25 mg per kg. Even MRS scores were not statistically significant between two dose groups. So conclusion is 0.25 mg per kg just as effective as 0.4 mg per kg with low rate of symptomatic ICH and 34% increase in blood flow following tenecteplase administration in patients who needed for thrombectomy. So in the another 10 volts trial, they have compared alteplase versus tenecteplase, the 0.2 mg per kg of tenecteplase versus 0.9 mg of alteplase. This functional recovery of MRS 0 to 2 at the end of 3 months was primary outcome, and it is analyzed by patient with safety outcome was analyzed by symptomatic ICH within the first 24 hours after administration of thrombolytic agent. And there were no difference in the NIHS on arrival or onset to ER on arrival time, and presence of large vessel occlusion and mechanical thrombectomy between both groups. And the results show that recanalization of large vessel after intravenous thrombolysis, the tenecteplase it is more 16.7 versus alteplase 8.3, and intracranial bleed is less with tenecteplase 7.3 versus 12.3, and symptomatic intracranial cerebral hemorrhage is also 5.5 versus 6.2. And MRS functional outcome 0 to 2 is tenecteplase 74.5 and alteplase 87.7. That is, there is no significant difference in long-term functional recovery in both groups, comparable safety profile in both groups. In the last study, tenecteplase a give and go stroke treatment, the 0.25 mg of tenecteplase used, and safety outcome as assessed in the symptomatic ICH at 24 hours, large vessel occlusion patients, early vessel opening assessed by angiogram, and clinical success was determined by MRS score at 3 months. And this conclusion show that tenecteplase should be considered as an alteplase, especially at sites that need to transfer patients for thrombectomy. Coming to the guidelines, IVA TPA should be administered to all patients within 4.5 hours of last known normal. Center should attempt door to needle time less than 60 minutes, and prior to TPA, a non-contrast CT scan and glucose are the only required tests, and patients who are candidates for mechanical thrombectomy, urgent CT or MRI angiogram is recommended, but this should not delay the treatment for IV TPA. And coming to tenecteplase might be considered as an alternative to TPA at 0.4 mg per kg as bolus. It is not been proven to be superior or non-inferior to alteplase. In patients with minor neurological impairment and no major intracranial occlusion. But this has been recently updated in 2019. It may be reasonable to choose tenecteplase, a single IV bolus of 0.25 mg per kg over alteplase in patients without contraindications for IV thrombolysis who are eligible to undergo mechanical thrombectomy. And this is a guidelines from Government of India. IV thrombolysis in 0 to 3 hours IV tenecteplase or alteplase, and 3 to 4.5 hours IV alteplase is recommended. Thank you.
Thank you, Dr. Rajesh, for explaining us clearly about the controversies between the tenecteplase and alteplase. Any questions? So as per the guidelines, one question from my side. So as per the guidelines, you told that there are a lot of trials. Initially, you told that there were head-to-head comparison and all, but the doses have been, initially you told 0.4 mg per kg is used, 0.25 mg is not efficacious, but the guidelines recommend it's finally the 0.4 mg per kg. Is there any specific selection criteria? And right now that the recent guidelines have showed it's got a significant role. Is there any selection criteria?
It is 0.4 mg per kg is an alternate to alteplase. Is an alternate to alteplase, but 0.25 milligram per dose is they have told it is better over alteplase. They have recommended, especially in patients who are planning to undergo mechanical thrombectomy. Based on the studies, NORTEST extend 1 year trial.
If there are no further questions, we will move on to the next talk.
Thank you.
Thank you, Dr. Rajesh.
Thank you.
This session, the next talk is a guest lectures. We'll start in a couple of minutes.
చేస్తారా పెద్ద సౌండ్ ఎప్పుడో ఖర్చు ఇచ్చేసుకోండి ఎప్పుడు వచ్చాను
We will go on to the next session of the day and the last session of the day. We move on to the guest lecture session. For this, we have 3 speakers. I first invite Dr. Rama Reddy sir, who will be speaking on Alzheimer's disease in diabetes patients. And to chair this session, I welcome Dr. Rajesh sir and Dr. Ashutosh Prasad sir.
Good afternoon, sir. And it's a privilege to introduce Dr. Rama Reddy, sir. Dr. Rama Reddy, sir, is Dr. B.C. Roy National Awardee, and he has Dr. D.L.N. Murthy Rao Oration Award, and he has IMA National Diamond Jubilee Oration Awardee, Dr. Amit Bora Oration Awardee, IMA National Dr. Menda Oration Awardee, and GAPIO Lifetime Achievement Award, Dr. Vaidilingam Oration Award, and Visakha Oration Award, and Civic Reception by Rajahmundry Municipal Corporation, and more than 50 awards or titles. And he has National Limca Book and World Records and Guinness World Book and Wonder, Golden Star, etc. for most varied education qualifications of more than 31 degrees, diplomas, and certificates. Is the past president of Indian Psychiatric Society and South and Journal branch. He has treated more than 136,000 psychiatric patients. I welcome you, sir, for the session.
Shall I share my screen, sir? Shall I start it?
Yes, sir. Please start, sir.
Please remove that screen so that I can share my screen. Yes. Am I audible, sir? Am I audible?
You're audible, sir.
My screen is visible?
Yes, sir. Your screen is visible, sir.
Okay. Thank you, madam. Good evening, everybody. Today I am expected to speak something on Alzheimer's disease and type 3 diabetes. I know it is a controversial issue, but I have taken purposefully so that it sensitizes our professionals. I welcome you all for this session of Neurocon 2020 second day neurology session, and I pay my respects to organizing chairman Ravi Garu and secretary Venkatraj Garu, and also the president Shashri Rao Garu, vice president Varaprasad Garu, secretary Vijay Sekhar Garu, and also I thought the chairpersons would be Srinivas Reddy garu, Pushparaj garu, and Rajesh garu. Anyhow, Rajesh garu is there, and my respects to Astosh Prasad garu and Madam who is conducting all the things. First of all, let me start with a disclaimer. I am not a neurophysician. I am neither a neurophysiologist or no neuropathologist. I am not an endocrinologist or a diabetologist. I am not an expert in nutrition science. I am not a fan of any socially active non-medical diet advisors. I am a psychiatrist, 66-year-old perpetual learner. That's my qualification. So I entered into this controversial thing. As you know, we have got billions of neurons, trillions of synapses, and among those synapses, quadrillions of permutations and combinations of connectors. So much wealth of brain we have got. But in spite of that, unfortunately, great intellectual person, a renowned professor, at the age of some 60 or 70, losing his brain. What is the reason? Alzheimer's disease. I think most dreaded disease which anybody would fear is Alzheimer's disease. I would prefer to get a heart attack rather than getting an Alzheimer's disease. Usually, this is the situation. When we think about the deficits, neurotransmitter deficits, degenerated neurons, synaptic dysfunction, extracellular buildup of amyloid beta, intracellular neurofibrillary tangles, so those things, the pathology we could understand. And when we go into the details also, so many toxic things, brain atrophy, neuronal toxicity, aggregation of the plaques, tangle formation, aberrant brain activity, and cholesterol or lipid metabolism down, neurogenesis down, glucose metabolism down, synaptic functions down, and the clearance of the plaques is gone down, vascular function is down, mitochondrial function is down. So much we could understand what is happening. And when we try to find out the reasons for this one, okay, we could find a gene, heredity, yes. If one gene is transmitted, yes, some extent. When from two parents, when both the parents, it is the risk is more, and it is more among the patients, not with the controls. So hereditary factors we could understand, and also post-mortem studies we could find the beta amyloid plaques, and also neurofibrillary tangles. But when the problem is elephantine, when we are blind, we try to describe the things in different perspectives. A psychologist describes in one perspective, and biochemistry man describes in another perspective, and pathology man and nutrition man also describes in some other perspective. And it is one of the perspectives. Alzheimer's disease is a metabolic condition. We know that diabetes or insulin resistance, type 2 diabetes especially, it is known to produce some changes in the brain. Alzheimer's disease, as you know, it produces them. And sometimes when these two things together, can we synthesize something? That synthesis is type 3 diabetes. Diabetes, whether it is DM1 or DM2, has influence on memory processing. We know it produces brain atrophy and synaptic communication disruptions. And on one hand, when we study about the diabetes, we think about the genetics, physical exercise, insulin, age, food, all these things. Even we try to prevent the diabetes also in pre-diabetics, prone people. And from Alzheimer's disease, we think about the so many symptoms and all, and we try to we have produced so many drugs to improve cholinergic function or so and so on. So many things are happening from this side, and from the other side also things are happening. Earlier it was found that those people who are having diabetes, whether it is T2 or T1, especially T2, they have independently, although Alzheimer's disease and diabetes are independent metabolic disorders, if we, even if we think, but there are certain common pathophysiological changes occurring in the signaling pathways, and also insulin resistance responsive for inflammatory pathways. So let us try to link these two things. Insulin resistance could be there here, could be there, and signaling, IGF signaling is defective here and there. Inflammatory response, oxidative stress, and also signaling mechanisms of other systems, amyloid beta plaques, neurofibrillary tangles, acetylcholinesterase activity regulation. So all these things can be found here, can be found there also. So here the hypothesis is without even type 2 diabetes, if similar changes occur in the brain and it leads to Alzheimer's like disease, can we call it as type 3 diabetes? Because diabetic symptoms are not there, hyperglycemia is not there, and he is not found to be diabetic at all, but still he has got insulin resistance and all the other symptoms are there, and the brain is deteriorating, brain function is deteriorating. This insulin resistant neurotoxin, neurodegeneration, especially hippocampus, insulin signaling, and leading to the disruption of the memory and executive functions. Increased prevalence of insulin abnormalities and insulin resistance is the crux of the problem, for which because of which we are calling it as type 3 diabetes. Brain, you know, it is an organ of bulimia. It is although it is of 2% size, it consumes lot, 10 times more than what its weight is. Brain's typical requirement of glucose per day is 110 to 145 grams per day. When it is reduced in the form of, see, metabolic rate of glucose, when it is reduced from the baseline, then 50 to 80 showed aged between aged 50 to 80 showed when the reduction is there, there are cognitive dysfunctions almost leading to Alzheimer's disease. Larger the reduction in the metabolic rate, quantitatively also, not only qualitatively, quantitatively also, more reduction in the metabolic rate of glucose, higher the risk for cognitive decline. So it indicates that there is something going on fishy, whether in the periphery diabetes is found or not, because of the starvation. The brain is, when the brain is relatively starving, when the brain's energy supply is somewhat disrupted, memory and cognition gets impaired. So this is the hypothesis. Glucose hypometabolism, although we are linking with Alzheimer's disease, many symptoms can occur, like tremors, sleep disturbances, sometimes Parkinson's symptoms, anxiety, anger, depression, concentration, lack of concentration. So many symptoms can occur with the hypometabolism of glucose. Just simply hypoglycemia man, he can get so many symptoms, is not including delirium, and he can go into the stupor and so on. So similarly, hypometabolism, when it is going on for months together, it leads to many things. Our concept is brain energy deficit precedes cognitive decline in conditions of increased risk for Alzheimer's disease. It is practically observed. Clinicians like me, we clearly find it is a case of dementia, probably Alzheimer's. But when we go for MRI or so, normal. But after 6 months or 1 year, it shows brain atrophy. That means even before we could detect the brain atrophy in the scan, we could clinically detect this one. Here, even 5 years before also, even 7 years before also, before the cognitive decline occurs, we could find the energy deficit with PET scans and all, so that he is the man who is going to have this cognitive deficit, minimum, initially minimal cognitive deficits, and later he may land in Alzheimer's. We can predict even many years before if we could really care for that one. This is the concept. Regional brain glucose hypometabolism in young women with polycystic ovary syndrome, when PET scans are done, they showed deficits in working memory, and they showed abnormalities in the form of hypometabolism of the glucose. For a polycystic ovary syndrome woman, we don't suspect anything at the stage, even 24-year-old woman also. Then we can predict that this woman is going to land this one. One controversial issue is here in insulin resistance, the hyperinsulinemia is occurring. Is this insulin is crossing the brain blood barrier and entering into the brain, and it is destroying the brain cells? It is a controversial issue. Insulin circulating in the blood can cross BBB through a receptor mediated active transport system, they say. Then naturally hyperinsulinemia, hyperinsulin should be there in the brain tissues also. But converse is also seen by some of the studies. This I'm going to explain in a few minutes. Insulin regulates the expression and levels of GABA, NMDA, AMPA mediated mechanisms which have strong influence over long-term potential. See, all the memories we cannot store, is it not? See, in the RAM we keep the memories, and after some time we keep in the hard disk. And from the RAM, so many things will go away. Even in the hard disk also, maybe disuse atrophy may occur for the memories. See, this long-term potentiation, long-term depression, these things are controlled by insulin. Fully differentiated neurons are permanently post-mitotic cells which lack regeneration. We know that neuron cell cannot be regenerated once it is dead, but still the others can take over the function. That's what we call as neuroplasticity in the form of forming the new connections and all. This because of the lack of ATP, because of the energy crisis, oxidative stress, they either die or experience apoptosis. Degeneration can cause neuronal degeneration and loss. Brain neurons or tissues are highly demanding excitable cells in which more than 40% of the present ATP is based to keep neurons viable. Just to live, just to make the viability, 40% of the ATP is required. And not only the neuronal cells but also the astrocytes, glial glucose transport system also should be okay to supply the energy, otherwise it may get disrupted. Free radicals, oxidative stress, dysfunction of mitochondria, energy defects, and neuronal degeneration. So these are the things which can occur because of the metabolic error in the. Then how can we nourish the starving neurons? It is a it is a nutritional approach towards Alzheimer's. They are having hypometabolism of glucose. Glucose supply is so badly affected because of the insulin resistance also. So how to go across this problem? Preservation of cell architecture is necessary. Although we think that when the brain tissue is atrophy, that means we find some atrophy in the cells, all the cells need not die. They may go into hibernation like. They would be shrunken, neurons may get shrunken. So to maintain the cell architecture, they require some energy. Cell membrane physiology, whether it is okay or not. And also dysfunction of the mitochondria, which are the batteries or powerhouses of the cells, which has to be maintained well. So here in type 3 diabetes are the diabetes-like syndrome which is affecting the brain without having diabetes type 2 symptoms in the body, like hyperglycemia. Predominant abnormality is 40% reduction in cerebral glucose utilization. Brain hypometabolism is responsible for this one. Progressive region-specific declines, especially those which are vulnerable, like hypothalamus or hippocampus, or so the areas where which are sensitive, cerebral glucose metabolic rate is down. Insulin is supposed to be the villain. One of the titles of a book is Insulin the Stupid. That means insulin, of course, I mean, insulin is, see pain, for example, or fever. Those are all protective in nature. But at the same time, we blame them. Similarly, insulin, which has got a lot of role in the body functions, it is responsible, it is the villain for abdominal obesity, PCOS, low HDL and high triglycerides, hypertension, gout, skin tags, erectile dysfunction, BPH, and so on. Here, hyperinsulinemia, even before the onset of mild cognitive impairment, cerebral metabolic rate of glucose is down because of hyperinsulinemia. Because of the time pressure, I'll go through fast. See here, because of brain insulin resistance, the cell membranes do not allow the insulin to act on them. So when the insulin sensitivity is lost, naturally glucose cannot enter into the body. So body in the sense of body of the cell. And at the same time, it produces so much insulin is accumulating there. When insulin is accumulating there, immediately it has to be mopped out. to mopping out certain enzymes are there. So those enzymes are taking the function of mopping out the insulin. Then this beta amyloid, because it is not taken care of, it accumulates. Normal blood sugar level, normal A1C, normal everything, OGTT, glucose tolerance test, it is also normal. But still, when insulin is tested, hyperinsulinemia occurs. Unfortunately, it is so it so happens that insulin is tested sometimes fasting insulin, and invariably it comes normal. See, when we go for vitamin D levels, for invariably it goes low. B12 estimation, invariably they give low results. Similarly, for insulin, somehow, although there are symptoms of hyperinsulinemia, fasting, for that also they have given explanation. Fasting is not sufficient. Go for 5 hours after food, insulin. So that gives the best result, people say. When hyperglycemia is happening, naturally insulin gets secreted, and because insulin is going up and up, this insulin is telling, come on, cells, take the glucose, absorb the glucose. So it tries to push the thing, but ultimately this blah 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 from the insulin will not be listened by the cells become deaf, and okay, whatever you shout, I'm not going to open. The locks and the key will not be compatible. So more the glucose we put into the body in the form of diet, or so more insulin will be secreted. In spite of the more insulin, unfortunately cells are not in a position to absorb. So here the similar pathology occurs in the brain also. But here, surprising thing is insulin, whether it is high in the brain or low in the brain. Insulin initially goes high, but as soon as it enters there, it gets mopped up. So finding the low levels of insulin, people try to give nasal sprays of insulin so that insulin improves. Even diabetologists also sometimes do the same thing. DM2, type 2 diabetes, although it is known that insulin resistance case, if the oral diabetic drugs fail, they try to give insulin. Although it looks, why giving insulin when insulin is more? No, insulin works so well. Similarly, insulin is given, and they found some initial improvement, but that is not the thing. It is like for a delirium tremens man, if we give alcohol, he becomes all right. But it is not the permanent thing, is it not? Similarly, here also. And this insulin resistance, insulin's function is to send glucose into adipose tissues, skeletal muscles, liver, glycogenesis, so on, so on. All these things you know. See, this resistance to insulin, it's one thing. The second thing, because of the hyperinsulinemia, ultimately the pancreas gets fatigued and it stops secreting proper insulin. So two defects, burnout, something like burnout. Because of the time pressure, I think I'll go fast. So these are the alteration in the brain metabolism, decrease in the glucose metabolism, insulin resistance, alteration in the amyloid precursor proteins, amyloid beta toxicity on one hand. Here, defect in the signal transduction, tau hyper phosphorylation, microtubules breakdown, mitochondrial dysfunction, oxidative stress, here cytokinins activation, inflammations, so ultimately leading to neuronal death. This amyloid beta peptides, say, different types are there, and also gene wise also different mutations are there, especially hippocampus, hypothalamus, cerebral cortex, and olfactory bulb. These are the things which get affected, and various mechanisms also have been delineated how the neuronal damage occurs, various angles, microglia and insulin signaling, synapse failure in uh, various areas, leading ultimately to the death of the cell. And these things also skip inflammation, apoptosis, long-term potentiation. In a normal man, long-term potentiation and long-term depression is down and long-term potentiation more in a healthy adult. Whereas in type 3 diabetes, it gets reversed because of these problems. This also various mechanisms. This also I skip. Glucose transporters, hyperglycemia, leading to this one. This gene, what is it happening? See, we have found some genetic material which is responsible for the genesis of for the development of Alzheimer's disease. But for the expression of this one, the other factors like metabolic factors also should be responsible. It is something like seed and soil. See, the children who inherit the diabetes gene from the parents, all of them may not become diabetics. Some may get the disease, some may not get the disease. It is because of the seed and soil thing. Similarly, one gene, two genes, deleterious effect because of the genetic overload, and also the high carbohydrate diet, which is responsible for this precipitation of the thing. ApoE4 accounted for approximately 24% of the general population and more than 50% among Alzheimer's disease, is responsible for interrupting how the brain processes. Here again, whether this gene is responsible for this metabolic error or metabolic error is responsible for genetic expression is also a controversial thing. The clumps, because of this gene, the protein that becomes sticky, and because of the stickiness of the protein to the cell membranes, naturally the absorption or the sensitization of the insulin sensitizers will not occur because of this thing. The clumps get trapped there because of the sticky protein, they say. Insulin signal processing would get impaired because of the protein. Then amyloid plaques. All these days people are thinking that these plaques are destroying this thing. Then why these amyloid plaques are these pathological? Even normal people also would be having that one, but immediately gets mopped off. Whether those are cause or effect. See, fire is there. Either fire due to short circuit or short circuit is due to fire. Both the things can happen. Similarly, these blocks also, there is enzyme called insulin degrading enzyme. It is something like a mother is having two children or three children, and mother has to take care of both the children, and somehow mother would be having, maybe having a favorite child, and may not, although children are equal, one favorite child. See here, insulin degrading enzyme has the favorite child is insulin, and whenever insulin is coming more into the brain, insulin degrading enzyme would be acting on that one, so that neglecting our amyloid beta protein. So amyloid beta protein gets accumulated. It failed to stimulate the clearance of amyloid beta protein because of the insulin effect. Susceptible to neurotoxic insults. The plaques hippocampal atrophy, lower cerebrocortical glucose metabolism with insulin resistance. Decrease neuronal inflammatory cascade. The cause and effect, toxicity cause. See, because of that, this amyloid beta protein, this toxicity can produce insulin resistance. Some people think that means again cause and effect. The plaques are responsible for insulin resistance. Some people say even. So these are the things which have to be naturally unraveled in the future studies. Glutamate induced excitotoxicity leading to neurodegeneration, and calcium overload, NMDA and AMPA receptors. What happens is because of this insulin resistance, there is the membrane mechanism, cell membrane mechanisms get disrupted, leading to influx of lot of sodium, a lot of calcium, and leads to bulging of the cells, and the potassium would go out, and this influx of calcium is responsible for the destruction of the mitochondria, leading to neurofibrillary tangles, they say. And cholinergic neurotransmission, we understand more about that one, and we have produced many drugs also to improve that one, and hormonal changes also can occur. These changes, hyperglycemic, glutamatic uncontrol. Then insulin resistance. See, when this hypothesis or when this concept is talked about, then Alzheimer's disease, I think we can detect some 5 years or 10 years before, is it? By finding insulin resistance in the body. Yes, it looks so beautiful. Fasting insulin and also the HOMA-IR test, that is homeostatic model assessment of insulin resistance. That is the simple formula: fasting blood sugar into fasting blood insulin divided by constant 404, and certain levels are fixed. If such certain level is there, it is mild insulin resistance. If certain level is more, it is a moderate, and so on. And insulin level 5 hours after OGTD, this is a very important, card says. And this is another controversial thing: statin drugs. These days, so many publications are coming out that statins are no good at all. But people, our physicians say that statins we have been using for decades together. They reduce the dyslipidemias. They correct that one. How can we blame statins? But they say that because of statins, some cognitive deficit. Indeed, the brain needs cholesterol. We should not interfere with the cholesterol. It is not the high fat which is responsible for the havoc. It is the high carbohydrates which are responsible for the whole thing. Higher cholesterol is, to some extent, it is protective only, people say, for healthy aging. This one, okay. What do we do about it? This consequence is the conflict between the age old. 100 years back people were eating in one way, and nowadays we are eating in a modern way. So nowadays diabetes more, Alzheimer's also more. If we revert back to the earlier stages, then I think we can prevent Alzheimer's, and we can have Alzheimer's antidote, like we can reverse it even. Amy Berger, a nutritionist, she has written a book, Alzheimer's Antidote, and which is the one of the best sellers. And she is a protagonist for this type of concepts. What it is said is, human brain, it is a hybrid car. Like hybrid car means it runs not only on the petrol but also with electricity also. And we can do work with horses in a traditional way, or we can work with modern way with a tractor, something like that. So here the brain works usually with glucose, because plenty of glucose is there. But when the glucose is low, if we feed with ketones it can function so well. Indeed, ketone is preferred one, because ketone gives more energy. Glucose has to be pulled into the brain, but whereas ketones, when ketones are more in the bloodstream, they naturally go into the brain. So only thing what we have to do is put lot of ketones into the bloodstream, then those will be taken care of, and the brain gets normal. Ketone is supposed to be high octane brain fuel. See here, this shows that young healthy control, 95% glucose and 5% ketone, no energy gap at all, healthy. But old man, but without much more memory problems. Glucose intake is only 89%, ketone also less, 3%. So there is gap of 8% minus. Here mild memory problems, minus 12%. And mild memory problems, but 30 grams of medium chain lipids are fats are given. Then 3% improved to 7%. Mild memory problems, when 45 grams are given, then 10% improvement. So that means only minus 6% only. So by giving the ketones in the form of MCTs, there will be an improvement. 2 points are clear. Alzheimer's disease is at least in part exacerbated by chronic progressive brain fuel starvation. Attempting to treat the cognitive deficit early in the stage with ketogenic interventions is safe, ethical, and scientifically well founded. It is said not by nutritionists. These are said by our neurologists and physicians. People, when they hear about ketosis, oh, ketosis means pathological. No, pathological ketoacidosis due to diabetes and all, due to fasting and all, that is a different issue which would be high, whereas benign nutritional ketosis is of it is something like a shower, raining shower, whereas the pathological ketoacidosis is something like a tsunami. And we should not, or we need not think, compare both the things. When people say talk about ketosis, ketosis, by taking the ketogenic diet, kidneys get damaged, this thing damaged, and I know about a person who died. So even with our drugs also, with our anti-epileptics, with our antidepressant, with our antipsychotics, some people die, and those people who are skeptics about the modern medicine, they keep on criticizing. Psychiatry is nothing but brain destroying discipline, people say. So things of that thing happen, but is ketogenic diet really so unhealthy? As long as it is prescribed by a doctor, a medical doctor who knows about the person, one need not criticize about this one. Ketogenic diet may even diminish and clear beta amyloid plaques. So these are all not just saying things. These are all in PubMed from 2000 onwards till today. So many articles are there. Impaired lipid transportation, mainly this one. How to raise the ketones? Low carbohydrate. I am not saying that here are two things. One is ketogenic diet means taking only less than 10 or 15 grams of carbohydrates. So that is the thing. But moderate thing is low carbohydrate and high fat diet. That is taking up to some 30 or 40 grams of carbohydrate, which we all can do. Fasting is intermittent fasting. So many people are getting benefited with the intermittent fasting. Exercise, nobody can deny the improvement of this one. For this medium chained lipids, coconut oil, sesame oil, those are found to be very good. But one thing, even the palm oil also, although when we hear about the palm oil, that cheap palm oil with all dirty fatty acids and all, we may think. But even that one also, see this one, cold pressed virgin oils, they say. So those things would be beneficial. The ability of ketones to supercharge the body has been designated as super fuel, medium chain triglycerides, simplest and cost effective, prevention via diet, and starting with this low carbohydrate and increasing the essential fatty acids like omega-3 fatty acids. A nutrition, so many things are described: antioxidants, carotenoids, polyphenols, flavonoids, omega-3 fatty acids. Curcumin is known to produce pro-apoptotic signaling pathways in primary hippocampal neuron cultures. It hurts. Exercise. Metformin also they have tried whether it improves the insulin resistance. There are some studies which say that metformin improves. There are some studies that metformin does not have any. So ultimately, I conclude saying that I am not an authority on this subject, but at the same time, I have seen patients after viewing this thing. I have seen patients improving. I have seen patients really improving and getting back their cognitive functions, not only in Alzheimer's but in LB disease also. Lewy body disease patients also, although they are said to be somewhat having worse prognosis, and close people whom I could observe. I don't say that I have stopped the medicines. I have given this one as an adjunct and it has given some results. And of course, I am not supposed to say about the anecdotal things. Only thing is evidence based we have to follow, and lot of evidence we could see in PubMed. Alzheimer's disease as a metabolic condition also we can think about, as an adjunct we can think about, and without diabetes of other body organs or hyperglycemia, which is the hallmark of diabetes, we can consider Alzheimer's disease as type 3 diabetes even. And in that view also, in that perspective also, we can see that one. I think I have crossed my time. Thank you very much for giving me this opportunity.
Thank you very much, sir, for a very lucid presentation of a controversial futuristic topic. And thanks for the diet advices, which are in general very useful as on today. Now we invite questions on the topic.
Are there any audience?
It's anyway there on YouTube, sir. So there will be more later.
Okay. Yeah.
If there are no questions, we thank you so much, sir, and thanks for coming to the conference.
Thank you.
Thank you so much,
Thank you,
sir. We invite our next speaker. Our next speaker is Dr. Madhusudan Babu, sir. He'll be speaking on traditional versus newer oral anticoagulants.
Can I share my screen, please?
So, welcome, sir, Dr. Madhusudan Babu Garu. It's a great pleasure for me to invite sir to this conference. Myself being an alumni of Isaac, sir is now the superintendent of KGH and head of the Department of Medicine AMC. He graduated from and sir has trained more than 120 postgraduate students, and he has got various papers in national and international conferences. And he's also the president of Isaac Neuro Club. And more than his academic and professional growth and his achievements, sir is very approachable, always cheerful, and so nice to talk and interact with him. So today we'll discuss on a very nice topic. So far, for many years and decades, we have been using traditional anticoagulants. Now the newer ones have come and taken over the market, especially from the cardiology point of view, cardiologist side of point of view. So we'll see how much these are good enough for our neurological diseases, and invite sir to start the session. Thank you, sir.
Thank you, Dr. Astor. Is my screen visible and I'm audible?
Yes, sir. Yes, sir. Very much, sir.
Okay. Thank you. At the outset, I thank the organizers for giving me the opportunity to talk in this forum. Before I start my talk, I pay my respects to our senior professor, my guide, Professor V. Satyanarayana Garu, who passed away recently. Coming to my topic, Dr. Balbhadra Venkatraj asked me to talk on traditional versus newer anticoagulants. If it is one, it's okay, but both traditional and newer anticoagulants, it makes a big chapter. So I will try to concise and try to be brief on this subject. This we know these diagrams since our physiology days. These are vitamin K dependent factors, and this is extrinsic pathway where tissue damage activates 7A. And final common pathway is factor 10A, which converts prothrombin into thrombin, and that converts fibrinogen to fibrin monomer and then polymer with the help of factor 13. And now the latest drugs act either on factor 10A or direct thrombin inhibitors. So, coming to the oral anticoagulants, we have vitamin K antagonist anticoagulant like warfarin, and direct acting direct thrombin inhibitors like dabigatran, and factor 10A inhibitors rivaroxaban, apixaban, and doxaban. Among parenteral, we are familiar with unfractionated heparin and low molecular weight heparin. Coming to the history, in 1920s, a type of hemorrhagic disease struck the cattle in North Dakota and Alberta. And they have isolated a causative agent that is dicumarol. But in 1940s that came into the medical use, and the products were azinocumarol and then warfarin, which we are using most commonly. Coming to the heparin and low molecular weight heparin, heparin is usually endogenously produced linear polysaccharide isolated from porcine or bovine intestines with a molecular weight of 15,000 daltons. Whereas low molecular weight heparins, they are derived from enzymatic depolymerization of unfractionated heparin with a molecular weight of 4,000 to 5,000 daltons. Whereas fondaparinux is a pentasaccharide with only 5 saccharides and with a molecular weight of 1700 dalton. So the lesser the molecular weight, the more specific will be the action. So this broadly gives us the action. Unfractionated heparin inhibits both thrombin as well as factor A. Low molecular weight heparin has less effect on thrombin and it inhibits factor 10A. Whereas fondaparinux inhibits only factor 10A. This is the mode of action of these heparins. And renal function effects, this heparin, the renal function does not affect elimination, and therefore does not, usually we don't have to alter heparin in the usual doses, usual therapeutic doses. Whereas low molecular weight heparins are metabolized in the liver and excreted by the kidney. So we should be careful in giving low molecular weight heparins when the creatinine clearance falls less than 30 ml per minute. So what are the advantages of this heparin? Because once you give heparin, it has rapid onset and offset of action, allowing more flexibility in dose titration. And you can discontinue whenever it is needed. So monitoring is also easy. We are all having APTT, anti-factor N activity is available, and we can monitor easily. We can use in renal failure, and you have extensive clinical experience with heparins, and ability to reverse activity by protamine sulfate. And we have choice by both intravenous as well as subcutaneous route administration. Coming to the disadvantages, because of the short half-life, it needs continuous infusion to obtain the therapeutic levels. Of course, for venous thromboembolic episodes, you have subcutaneous route administration. And it is highly variable dose-response relationship necessitating frequent laboratory monitoring. And achieving and maintaining therapeutic levels is often challenging with this heparin. And there are no oral formulations. And this is another thing which we are usually encounter: heparin-induced thrombocytopenia, then of course skin reactions and osteoporosis and long-term use. Then potentially increased risk of hemorrhagic complications compared to low molecular weight heparins. And there is an entity known as heparin resistance, where once the daily requirement is more than 35,000 units, excluding the bolus doses, we call it as in resistance to heparin. Then a word about low molecular weight heparins. The advantages are it is a greater bioavailability than unfractionated heparin. Extensive clinical experience, all of us are familiar with these drugs, and once or twice daily administration in the outpatient setting, and administration of a fixed dose without laboratory monitoring, lower risk of heparin-induced thrombocytopenia, and lower incidence of osteoporosis. Disadvantages are onset of action is 20 to 30 minutes when compared to heparin, which the action is immediate. Then longer duration of action, making it more difficult to rapidly stop the therapy, and it is less easily inactivated with protamine sulfate. And prolonged half-life in patients with renal failure, especially enoxaparin. If monitoring is required, this may be difficult. Anti-factor Xa activity testing with a rapid turnaround time is not available in all places. These are the preparations which we use. Then coming to vitamin K antagonists, they are indicated, all of us know the indications: atrial fibrillation, acute coronary syndrome, heart failure, prosthetic heart valve, stroke, deep vein thrombosis, pulmonary embolism, and antiphospholipid syndrome. Then advantages with this warfarin, this vitamin K antagonist is we have a large clinical experience. All of us have used this drug, and greater efficacy in the prosthetic heart valves, because we cannot give other drugs in prosthetic heart valves. It has to be vitamin K antagonist. Then low cost and wide availability, and it is that drug that we have to use in antiphospholipid syndrome. And desired anticoagulant effect even in patients with advanced renal insufficiency. So it can be given in advanced renal insufficiencies. We can get the adequate concentrations. Then higher rate of thromboembolic bleeding and complication in individual with atrial fibrillation. Requirement for frequent monitoring with associated costs and burdens, because it has to be, this INR should be done very frequently. Dosing is affected by illness, changes in diet, numerous interacting medications. And green leafy vegetables interferes a lot with warfarin, and it contains large amount of vitamin K1, and many drugs interfere. it's very difficult to remember all the drugs. What I usually do is, whenever I start this drug, I ask the patient what drugs he is taking, and I see whether any reaction for that, and I ask him to hold the green leafy vegetables. And to memorize, for those who can memorize, they have given some tips like O devices and crab bars, and these drugs, omeprazole, disulfiram, erythromycin, valproate, isoniazid, ciprofloxacin, sulfonamides, all these things potentiates, whereas these drugs which we use in epilepsy, especially carbamazepine, phenytoin, barbiturates, they all decrease the effects of that, and alcohol reforms and sulfonylurea gas. But it's difficult to remember all the things, so we should always check the drugs which is taking before we start this drug. Then, because these other newer drugs are mostly depending upon the renal elimination, oral anticoagulants, direct oral anticoagulants should not be given in stages 4 and 5, CKD stage 4 and 5. Once the renal clearance is less than 30, then you should be careful and you should not use the direct acting oral anticoagulants. And this is a randomized evaluation of long-term anticoagulation therapy trial. In this, how to adjust dose of warfarin in relation to the INR that they have given. Like if it is less than 1.5, increase by 15% per week. If it is 1.5 to 1.99, increase 10% per week. 2 to 3 as what we want. And if it is 3 to 4, then decrease 10% per week. If it is 4 to 4.99, hold one dose and then start 10% lesser dose. And if it's more than 5, hold until INR is 2 to 3. Restart the dose, decrease by 15% per week. And the complications, all of us know, bleeding, skin necrosis, teratogenicity, especially in teratogenicity in pregnancy, cholesterol embolization, vascular calcifications, nephropathy, all these are complications with these drugs, skin necrosis. And now coming to the direct oral anticoagulants, this is dabigatran is the drug which we commonly, most of us are using. Of course, we are using other drugs also. Dabigatran etoxalate is an oral product that is rapidly converted by serum esterase to dabigatran. It is a direct competitive inhibitor of factor 2A, that is thrombin. It is a direct thrombin inhibitor. Because of predictable pharmacokinetics, dabigatran can be administered at a fixed dose and does not require coagulation monitoring. So dabigatran pharmacokinetics are affected by renal function because 80% is excreted renally, but it is not metabolized by cytochrome 450 system. So it is not affected by drugs that potentiate or inhibit this system. Whereas it is definitely affected by P-glycoprotein inhibitors such as ketoconazole, amiodarone, verapamil, and quinidine. Then coming to the rivaroxaban, this is a competitive inhibitor of factor 10A, and its half-life is 5 to 9 hours. Administered as a fixed dose without coagulation monitoring, and it is metabolized by CYP3/4A system, that is cytochrome P450 system. And so all the drugs that potentiates like clarithromycin, erythromycin, diltiazem, these are all inhibitors. And then inducers are phenobarbital, phenytoin, and rifampicin. Then rivaroxaban is metabolized by this system again, so this is affected by all those medicines. Clearance is both by renal as well as fecal, unchanged. They are excreted in urine and feces. Apixaban is also competitive inhibitor of 10A and almost same this thing, but long acting this thing. And apixaban is metabolized again by the same systems. Clearance again is both renal as well as fecal. And we'll quickly go through some studies. This is released trial in which they have shown, they have compared dabigatran versus warfarin in non-valvular atrial fibrillation, and they have shown that dabigatran 150 milligrams twice a day was superior, and dabigatran 110 milligrams twice a day was non-inferior to warfarin in preventing stroke and systemic embolism in patients with atrial fibrillation. So the study has shown the superiority or non-inferiority of dabigatran in 2 different doses. I have put up this here because this has come in last year's JAMA Neurology. The safety and efficacy of dabigatran versus dose-adjusted warfarin in patients with cerebral venous thrombosis. Dose-adjusted means according to INR, the dose is adjusted. And this I kept it here because most of us might be interested in cerebral venous thrombosis. And I will go a bit into detail into the study because this is a new thing that has come recently. This objective of the study was to compare the efficacy and safety of dabigatran etiolate with warfarin in preventing recurrent venous thromboembolisms in patients who have experienced CVT. Then coming to the design, it is an exploratory, prospective, randomized, parallel group, open label, multi-central clinical trial with blinded endpoint adjudication, that is probe design. And it was performed from December 21st of 2016 to June 22nd of 2018 in follow-up for 25 weeks in 51 tertiary sites in 9 countries. So, adult consecutive patients with CVT who are stable for 5 to 15 days of treatment with parenteral heparin were screened for eligibility. So, initially they are given 5 to 15 days parenteral heparin, then they were taken into the study. Patients with CVT associated with central nervous system infection or major trauma were excluded. But those with intracranial hemorrhage from index CVT case were allowed to participate. After exclusions, 120 patients were randomized in all these centers, and the interventions were dabigatran 150 milligrams twice daily or dose-adjusted warfarin for a treatment period of 24 weeks. The primary outcome was either recurrent CVT, deep vein thrombosis of any limb, pulmonary embolism, or splanchnic vein thrombosis, or major bleeding during the study period. Secondary outcomes were cerebral venous recanalization and clinically relevant non-major bleeding events. These are secondary. So the conclusions and relevance of the study are patients who had CVT anticoagulated with either dabigatran or warfarin had low risk of recurrent VTEs, venous thromboembolic phenomena, and the risk of bleeding was similar in both medications, suggesting that both dabigatran and warfarin may be safe and effective in preventing recurrent VTEs in patients with CVT. I have a small experience with this drug. I have used it in 13 patients, and 12 responded well. 1 patient did not improve, for whom I have to start heparin infusion followed by warfarin, with which he has improved well. So the dabigatran does work, and we can, when monitoring is not possible, I think we can definitely look at the dabigatran. Still further studies are have to come for us to give a standard guidelines. And this is another study, early start of DOAC for ischemic. How early we have to start? They have given either less than 7 days or more than 7 days. Early means are less than 7 days. More late means they said more than 7 days. And it is published in Neurology in 2016. And the conclusion of the study was, even if DOAs are often started early after an index event, the risk of ICH appears to be low. So you can start direct oral anticoagulants in early period. Within less than 1 week, we can start them on this direct acting oral anticoagulants. Among all patients receiving anticoagulation, the rate of recurrent events was 6 times higher than the rate of ICH. So you can start these drugs early. This is a meta-analysis published in BMJ in 2017, in which the data sources were Medline, pre-Medline, Embase, and the Cochrane library. The objective was to compare the efficacy, safety, and cost effectiveness of direct acting oral anticoagulants for patients with atrial fibrillation. So what they have concluded, what this study adds to us, to our knowledge, these direct acting oral anticoagulants as a class reduce the risk of stroke and all-cause mortality in patients with atrial fibrillation, and are safer with respect to major and intracranial bleeding than warfarin. So they have given a clear-cut upper hand in this study. Our cost effectiveness analysis provides that despite their higher cost, several DOAs are preferable to warfarin. Then they found that apixaban 5 milligrams twice daily was the highest expected incremental net benefit. So apixaban followed by rivaroxaban, edoxaban, and then dabigatran. This is the analysis of this meta-analysis study. Then without atrial fibrillation, deep vein thrombosis, this study was taken from Stroke, Journal of Stroke in 2018, and this shows direct acting oral anticoagulant shows superior safety to warfarin in terms of risk of ICH in patients with DVT. So in this study also, without atrial fibrillation, deep vein thrombosis or pulmonary embolism, these patients, DOAs show superior safety than warfarin. Then this is another article in JAMA Neurology, rivaroxaban versus warfarin. The two are compared in ultra early period of atrial fibrillation related to mild ischemic stroke, randomized clinical trial published in JAMA Neurology in 2017. So they have compared rivaroxaban and warfarin sodium in patients with AF-related acute ischemic stroke. A randomized multi-center open-label blind-ended point evaluation compared to phase 2 trial at 14 academic medical centers in South Korea, and they have concluded that in mild AF-related acute ischemic stroke, rivaroxaban and warfarin had comparable safety and efficacy. So both were comparable in this study. Then there is another study, early recurrence of major bleeding in patients with acute ischemic stroke and atrial fibrillation treated with non-vitamin K oral coagulant, RAFNOC study, that is published in Journal of American Heart Association 2017. And in that, they have concluded that in patients with acute ischemic stroke and atrial fibrillation, treatment with NOAs are associated with a combined 5% rate of ischemic embolic recurrence and bleeding within 90 days. So in 90 days, the combined ischemic and hemorrhagic events are only 5% according to this study. The rate of ischemic and hemorrhagic outcome events were 60% lower than the RAF study that included mainly patients treated with vitamin K antagonists. So this also shows the superiority of DOACs compared to vitamin K antagonists. So this study says a non-vitamin K oral anticoagulants could be used within 2 weeks from the stroke onset, given the seemingly acceptable risk of severe bleeding. And there was an editorial anticoagulation timing for atrial fibrillation and acute ischemic stroke in JAMA Neurology, published in 2011 September. And they recommended that anticoagulation of atrial fibrillation should be started 3 days after a mild ischemic stroke and 12 days after a severe stroke. They take the criteria of mild and severe. Mild means they took diffusion perfusion of the MRI images, and less than 1/3 of MCA atrial infarct and less than half of ACA atrial infarct they have taken, and in them they have started these drugs within less than 3 days. So, in summary, this triple XL trial, early anticoagulation with a direct oral anticoagulant and warfarin in patients with a mild stroke is feasible, but whether this is of benefit to all patients with acute stroke and AF has had to be demonstrated. And this is another study which was published in 2011 in New England Journal of Medicine, rivaroxaban versus warfarin in non-valvular atrial fibrillation, with a conclusion that rivaroxaban was non-inferior to warfarin for the prevention of stroke or systemic embolism. The average trial was terminated in between, in the middle, when the interim analysis found that apixaban was superior to aspirin. This trial compared apixaban and aspirin. So, what are the latest AHA recommendations for this? And it's very difficult to go through these congested slides because these are the recommendations, so we cannot change anything in them. And I will go through briefly the recommendation, but finally I will give a gist of these recommendations. So, warfarin and DOACs all are indicated for the prevention of first and recurrent stroke in patients with non-valvular AF. So, both are indicated. That is one guideline. Then selection of antithrombotic agents should be individualized on the basis of risk factors, cost, tolerability, etc. And the next recommendation is dabigatran 150 mg twice daily is an effective alternative to warfarin, provided the creatinine clearance is more than 30 ml per minute. And if the creatinine clearance is less than 30 ml, that's 15 to 30 ml per minute, dabigatran can be tried in 75 milligrams twice a daily dose, but its safety and efficacy have not been established. The class 2B level of evidence C for this recommendation. And dabigatran is not recommended in patients with creatinine clearance less than 15 ml. So if the creatinine clearance less than 15 ml, dabigatran should not be used. That is another strong recommendation. And then coming to the apixaban versus aspirin. Apixaban 5 milligrams twice daily is an efficacious alternative to aspirin in patients with non-valvular AF deemed unsuitable for vitamin K antagonist therapy. So the patient is not fit to give vitamin K antagonist. So instead of giving aspirin, the apixaban is proved to be superior to it. And they had additional risk factor and no more than one of the following categories. These three are taken in the guidelines: age more than 80 years, weight less than 60, serum creatinine more than 1.5. So if it's more than one of this is available, this apixaban 5 mg twice daily is advised. Then if the risk factors are 2 or more, that is age 80 years, weight, and then serum creatinine 2 or more, then apixaban is given at 2.5 milligrams twice daily. Then warfarin and apixaban. Apixaban 5 milligrams twice daily is a relatively safe and efficacious alternative to warfarin in patients with non-valvular AF. Okay. So the other recommendation is at least if additional risk factors more than 2 or more, then this apixaban 2.5 milligrams twice daily was advised. So apixaban 2.5 milligrams twice daily is better than warfarin in those who have one risk factor and the 2 or more of the following criteria. Apixaban should not be used if the creatinine clearance is less than 25 ml per minute. Then the 10th recommendation is regarding rivaroxaban, and rivaroxaban 20 milligrams per day is reasonable as an alternative to warfarin. Then if the creatinine clearance of 15 to 50 ml per minute, then 15 milligrams of rivaroxaban daily may be considered. Then the 12th recommendation is rivaroxaban should not be used if creatinine clearance is less than 15 ml. And the safety and efficacy of combining dabigatran, rivaroxaban or apixaban and DOAC should not be when they are combined with antiplatelet agent, that has not been established. So there is no use of combining antiplatelet drugs with direct acting anticoagulants. Then the conditions, heparin or vitamin K may be preferable in prosthetic valves, pregnancy, severe liver disease, and antiphospholipid syndrome. In this, there is no doubt that only vitaminic antagonists are chosen. And also gastrointestinal disease, history of bleeding. Individual with severe dyspepsia, they may not tolerate dabigatran. And dosing convenience, of course, rivaroxaban and edoxaban also once daily dose, and as warfarin. And cost effectiveness we have to see in our country. Finally, before I wind up, this is the latest journal published in June 2020, where direct oral anticoagulant use, a practical guide to common clinical challenges. They have given certain recommendations for these drugs. Dabigatran indications are same for almost all the drugs. So just go through this slide. The rest of the things I will go pass off. FDA approved indications: stroke prevention in non-valvular AF, number 1. Number 2, treatment of deep vein thrombosis and pulmonary embolism. Third indication is prevention of recurrent deep vein thrombosis and pulmonary embolism. Then prevention of thromboembolism after total hip replacement. These are the FDA approved indications. Then off-label indications are prevention of thromboembolism after total knee replacement, prevention of thromboembolism after percutaneous interventions with non-valvular atrial fibrillation. Next, again, same indication for rivaroxaban. And for apixaban, other thing that was added is treatment of heparin-induced thrombocytopenia. It is off-label indication. Otherwise, almost same. Edoxaban. So finally, before I wind up, this is the score. Basing on this, the above study has given recommendations. CHADS2 vascular score, and you know how the name has arrived. This is the way the name has come, and the total are 10 points in this. And what is the take-home message after going through all these trials and other things? Anticoagulant therapy is strongly recommended for atrial fibrillation related stroke prevention in men with a score of 2 or more, and in women with a score of 3 or more. In women with a score of 1 and in women with score of 2, anticoagulation should be discussed with the patient, and if the patient agrees, you can start. Men with a score of 0 and women with a score of 1 do not need to be anticoagulated. DOACs are preferred to warfarin for stroke prevention in atrial fibrillation because there is less bleeding with these agents than with the warfarin, and they are as effective or more effective compared with warfarin at preventing stroke in patients with atrial fibrillation. Patients with mitral stenosis and prosthetic mechanical mitral valve should not receive DOAC to prevent stroke. Warfarin should be prescribed. Then anticoagulation therapy is indicated in patients with atrial fibrillation with paroxysmal, persistent, or permanent atrial fibrillation. Whatever the type, that is indicated. Similarly, atrial flutter should be given the same importance as atrial fibrillation, and same type of treatment should be started. And in guidelines, the dabigatran did not acquire a seat for prevention of CVT, for treatment of CVT, and probably more studies will bring that into the guidelines. And thank you for the patient hearing. Thank you.
Thank you, sir. The session is open for any questions.
Thank you, sir, for the excellent talk. And are there any questions from the audience? If there are no questions, we'll proceed to the next talk.
Okay, sir. Thank you, sir. We shall now proceed to the last talk of the session. Gopi, sir, any questions, sir?
Question to Mr. Babu, sir. Sir, can I
Sir, do you have any questions, sir?
Am I audible, sir?
No, the
Can
voice
you
is
comment?
weak, Gopi. I'm not able to hear you.
COVID, sir. COVID, sir. COVID-19. In COVID-19, sir.
Yeah. COVID-19?
In COVID-19, sir. And then
Role of anticoagulants used in COVID-19 patients.
Oh, anticoagulants in COVID-19?
Yes, sir.
Yes, sir. Yes, sir.
Oh, anticoagulants in COVID-19, I think Dr. Buchrazu spoke about it. And because these are whatever the pneumonic patches in the lungs are secondary to clots of the thrombosis, thromboembolic events. So early start of once the CT shows that, and immediately we should start them on low molecular weight heparins. That is the indication. And the recent guidelines regarding COVID, I think Dr. Bujraj spoke.
Hello.
Bujraj.
Sir, you're audible, sir.
Yeah. I think Dr. Gopi is asking about prophylaxis of oral anticoagulants following COVID. Because when the D-dimers are elevated, many people are using oral anticoagulants, and many people are using, especially the newer anticoagulants, maybe because of the side effects which are less, like apixaban. Even many personal experience, people felt to use anticoagulants for 1 to 3 months. So I think because we don't need to monitor PT, INR and all that. So I think whatever I can hear from all other colleagues, most of the people were given apixaban, especially if the D-dimers are high above 500 units. So for 3 months. So I think that answers Dr. Gopi's question.
That's what most patients are doing. And even in Apollo also, they are doing the same thing.
Yes, sir. Thank you, sir.
My question is, what is the neuroanticoagulant role, especially in neurology like CVT? Because two patients have used, one patient actually had more trouble, like his vision has decreased. So I was again shifted to the traditional anticoagulants.
Yeah, that's what happened to my patient also. We have to give heparin infusion followed by again warfarin. They are responding well after that.
So I think before we jump in and use newer anticoagulants, we should need to have, because I think there are only few trials, 1 or 2 trials which have showed.
But our experience also shows, I have used only, of course, it's very minimal patients, 13 patients, 12 improved well, they recanalized well, and only one patient I had the problem. So we cannot totally rule out it. So we should wait for that's why it's not in guidelines, Vichras.
Yeah. Ashutosh, do you have any experience of newer anticoagulants in CVT?
Newer anticoagulants in?
Same, in cerebral venous thrombus.
Yeah, I use dabigatran.
Yeah.
My experience is only with dabigatran. I have used dabigatran in those patients.
Thank you, sir. And we'll proceed to the next talk.
If there are no questions, we shall move on to the next talk. The next talk is Management of Carotid Stenosis by Dr. Lakshmi Sudha Prasanna, madam.
Dr. Prasanna, madam. She is a consultant vascular and neurointerventionist at Apollo Hospital, Hyderabad, and Lalita Super Specialty Hospital at Guntur. She has presented papers at various national and international conferences, and she is a reviewer for Neuroradiology Journal, Stroke and Vascular Neurology, BMJ Neurology, and Pediatric Neuroradiology. Madam,
okay,
please
am I
proceed,
audible?
madam.
Am I audible?
Yeah, you're audible.
Yes, madam, you're audible.
Okay. Once. Good evening, everybody. My talk is on management of carotid stenosis. And first, I want to thank Dr. Rajgaru for giving me this wonderful opportunity. So carotid artery stenosis causes up to 10% of all the ischemic strokes. As you can see, once there is a atherosclerotic plaque, subsequently there will be stasis, and then there is development of wall thrombus and subsequent embolic episodes, after which there will be stagnation and formation of red clot. This is how the carotid artery stenosis will progress to total occlusion. So what are the various vascular imaging we do in ischemic stroke? Carotid Doppler, MR angio, CT angio, and DSA, which is considered as the gold standard of above all the investigations. So what is the indications of DSA in ischemic stroke? Presence of bruit, presence of stenosis in Doppler or MR angio, because both of these are subjective, and in MR angio there are more of flow relative artifacts. Intracranial stenotic lesion on MR angio, because we do not know how much the artifact is affecting on MR angio. Recurrent or crescendo TIS, especially in the same territory, and suspected dissections. That's here DSA is again the gold standard. So the main indication, just to give a start, for carotid angioplasty and stenting is symptomatic greater than 50%, asymptomatic greater than 70%, lesser if opposite side is totally occluded. This is a treatment of choice, especially in post-radiation and post-carotid endarterectomy stenosis. Usually, it's better to do as early as possible. We only differ in presence of large infarcts by 3 to 4 weeks. And by large infarcts, I mean greater than 1/3 of the territory. The main contraindications, which personally I strictly follow, and also all of us, especially in India, we follow, is presence of thrombus is a strict contraindication. Severely tortuous vessels, that again is operator dependent, and serum creatinine greater than 2.5. It is not possible in total occlusion. So let me start with a couple of cases. So is a 60-year-old gentleman, diabetic and hypertensive, with left MCA TIA 1 month back, and with the left MCA stroke 3 weeks back, where you can see the left temporoparietal infarct on the CT, and Doppler showed greater than 80% stenosis on the same side. So here you can see, by the time I did the DSA, here you can see greater than 90% stenosis of the origin of ICA. And it's just not important to see the neck vessels. It's always important to document the intracranial circulation. We may miss tandem lesions, or we may miss other causes, or we may miss total occlusion of the T occlusion of the supraclinoid ICA. So here you can see poor intracranial flow. So we went ahead, and this is this arrow is actually showing the spider device. This is a protection device, and this is the stent. This is after placement. You can see how the vessel is nicely reconstructed after the placement of this stent. Just not important is placing the stent. Here you can see the increased intracranial circulation. This is actually the goal of doing carotid stenting. The primary reason we are doing is to increase the intracranial circulation. So another example, 67-year-old smoker with right MCA territory stroke. He was admitted after the DSA. He had a recurrent onset stroke on the in the hospital. So Doppler showed 90% stenosis, and the fresh infarcts in the right MCA territory, and this is the right stenosis and poor intracranial circulation. So the technique is same, just placement of the stent and protection device, which I always follow. And then there's an increased intracranial circulation. So what are the advantages over surgery? It is done under local. Patient is clinically monitored during procedure. So no incision, no scar procedure. Risk of infection is low. Safe even when opposite side is totally occluded, where carotid endarterectomy is contraindicated. This is a treatment of choice in radiation vasculopathy and restenosis after CEA. And on-table control angio is done, so we can handle all the complications. So when I am speaking about carotid stenosis, it will be incomplete if I don't speak about the trials. So usually the first trial is NACET trial, which showed a significant improvement in the patients in 70 to 99% group with carotid artery endarterectomy. Before this, it was only medical management. And then came the SAPPHIRE trial, which ultimately concluded that carotid artery stenting was not inferior to carotid endarterectomy. Then, after these trials, the intervention group was hit by these two trials, SPACE trial and EVA-3S trials. However, they were criticized for their suboptimal credentialing and experience requirements in the carotid artery stenting group. Then, ultimately came the CREST trial, which, just to conclude, I don't want to bore with the details of the trials. It said that previously randomized controlled trials comparing carotid artery stenting and endarterectomy arms have been criticized for suboptimal credentialing and training of stent operators. But till today, the CREST credentialing and training is the most rigorous reported, and it is used as a model for many future trials. And in the CREST trial, as you can see, periprocedural stroke is actually more in the stenting arm group, and periprocedural MI is more in the endarterectomy group. Of course, the primary endpoint is nearly same in both the groups. And cranial nerve palsies are more in the carotid endarterectomy group. Cranial nerve injury is not benign. 80% of cranial nerve injuries involve motor deficit. So the main conclusions of this is CREST is the largest and most rigorous trial. So there are serious lacunae in European trials. Carotid artery stenting and carotid artery endarterectomy primary endpoints are same in the CREST trial. More minor strokes in stenting arm, more MIs and cranial nerve palsies and access site complications in the surgical arm. Overall complications are within acceptable limits, and cranial nerve injuries are not benign and they cannot be ignored. Coming to protection devices, there are two types of devices which we use in stenting. That's occlusion devices and filter devices. The main difference is occlusions are proximal protection. So before crossing the lesion itself, we just occlude. These are just various pictorial depicts of these devices. Personally, majority of the people like distal protection devices because they are easy to use. These are the various designs of the distal protective devices. And this is actually, you can see this is a distal protective device. This is what is collected in it, and we have sent it for histopathology analysis, which showed the clot. And so this is our initial experience, which was showed the importance of protective devices in the carotid angioplasty and stenting group. So coming to the special situations, especially, let us see one by one. So in bilateral carotid artery disease, let us see with example, 52-year-old gentleman, diabetic and hypertensive, presented with left MCA territory TIS and recurrent TIS in spite of antiplatelets. CT angio showed severe stenosis of bilateral ICA origins. And this is the right side ICA stenosis, and this is a symptomatic stenosis, which is more tight. So obviously, always we treat the first side. The technique is the same, distal device and the stent is placed. And this is the opposite side, which is treated on the same sitting. So bilateral is treated on the same sitting. So this is initially we were a bit hesitant to do bilateral in the same sitting. So we have done in few patients. Then once we are okay with this, we went ahead, and then the main indication, even in high risk groups, especially with poor cardiac reserve, patients awaiting CABG, we can actually cut down instead of a stage on procedure, we can do a simultaneous bilateral carotid stenting. With the important thing in simultaneous is the selection criteria. So let us see CCA. The 32-year-old gentleman is a known case of Marfan syndrome, presented with cardiac failure 1 year back because of aortic regurgitation, who underwent aortic valve replacement, and he was on anticoagulation since then. So he presented with history of neck pain and recurrent motor TAS, right MCA territory. However, there were no acute infarcts. We saw on CT angio dissection involving the right CCA. So in spite of antiplatelets, the TAS persisted. So as you can see, this is the arch, this is the wall, old replaced wall. You can see the proximal dissection here. And then the distal CCA, severe stenosis with dissection. Luckily, the intracranial circulation is normal. So this can be treated. So we did this in a staged procedure, stage 1 and stage 2. So in first step, we stented the proximal lesion, and then this is the first step, and then in the procedure 2, we stented the distal lesion. So this is the final. You can see the 3 stents, telescopic stents, and good intracranial circulation. Patient did not have any further TIAs or minor strokes. It was totally uneventful and discharged, and patient was discharged on warfarin. So this is actually was published. So stenting of tandem lesions. Tandem lesions are extracranial ICA and ipsilateral, either intracranial ICA or ipsilateral MCA lesions. About 10 to 15% of the patients with carotid disease has tandem lesions. The reason for doing tandem stenting or even treating tandem lesions is because both are symptomatic. We do not know which is actually the cause of symptoms of the patient. And since it is in a single axis, we can finish both the things in the same setting and come out. If we just treat the extracranial stenting and if we leave the intracranial part, he may come out, he may come back with the recurrent symptoms, though we will be only partially treating the lesion. We may be treating the neck lesion, but patient may still continue to have recurrent stroke, recurrent TIS. So, however, the higher risk of post-procedural stroke in the series of tandem stenting, we need to see careful risk assessment of risk-benefit ratio in these procedures, because most of the times we miss the tandem lesion. So it's always important. We need to see the tandem lesion. We need to address it. It may be same sitting or next sitting, but it has to be always addressed. So let's see the example. This is a 65-year-old diabetic and hypertensive gentleman with recurrent EAS and minor strokes in spite of double antiplatelets and statins. You can see left MCA territory acute infarcts on DWI. And here is a left ICA origin stenosis here. And you can see left petrous ICA stenosis. Also there is mid-basilar stenosis. This is the ICA stenosis. There is a tight petrous stenosis. This patient, if we treat the carotid stenosis and leave this, he is going to have a increased perfusion, but he is going to have a recurrent symptoms. Of course, there is also intracranial vertebral artery stenosis. So this patient, obviously we treated first the ICA and then went in and placed a small coronary stent in the petrous intracranial ICA and then treated that, and both the lesions were treated in the same setting. So coming to a good special situation, internal carotid artery thrombus. So initially in the NACET trial, the frequency of ICAT was seen in 5.5% of the patients. That time we did not know the importance of this. And then the antiplatelets, death or stroke at 1 month, it was actually 11% in the patients in the ICAT group, that is with the thrombus group. And also the perioperative stroke or death were more in the patients with thrombus. So in a retrospective study, it has found that initial anticoagulation for symptomatic thrombus related stenosis, it leads to low rate of recurrent events, and carotid revascularization can be performed after an initial anticoagulation. Let me show you an example. The 70-year-old gentleman, hypertensive and diabetic, who presented with acute onset left side weakness. And on examination, he had left UM and facial palsy, dysarthria, and 4/5 power. You can see the large infarct in the right MCA territory. On MRI, we do not see the intracranial circulation because of the tight stenosis. So the reason is this is all a thrombus. There is a thrombus. There is, of course, there is a tight stenosis in the CCA, and there is a thrombus present here. So this lesion, if we stent it, it is going to fly ahead. So because of the thrombus, the patient was kept on low molecular weight heparin for 2 weeks, and he was treated with dual antiplatelets and statins. He did not worsen, and power improved compared to the pre-medical levels. And repeat DSA showed, this is a pre-DSA prior to anticoagulation. Here you can see the clot has actually, the thrombus has actually disappeared. Now this lesion can be safely treated. So it's technically very normal, straightforward. You can just place the stent and then the vessel is reconstructed. So CABG and carotid stenosis, the common clinical questions we are always asked here. So the incidence of stroke after CABG, especially with unilateral disease, it's around 5%. With bilateral disease, that's greater than 50%. It's increases up to 7%. So the etiology of stroke after CABG, surgery-induced hypercoagulable state, stoppage of antiplatelet drugs, dehydration, embolic from plaque or hypoperfusion, or post-op atrial fibrillation. So according to American Heart Association guidelines for managing carotid stenosis, especially in symptomatic, there is no, in the symptomatic group, we really, it's not recommended, but in the symptomatic group, it is reasonable to consider carotid revascularization in conjunction with simultaneous or staged intervention. In the asymptomatic group, we need to see the high risk features. That is presence of bilateral, unilateral with contralateral occlusion. Even if it is a single-sided carotid, it's better to treat this. And unilateral with impaired cortical reserve, it's better to see this, especially if CT or MR perfusion is not available, we can use a DSA for assessing the cortical reserve. Management options, either endarterectomy or carotid stenting. Advantages of carotid artery stenting, it's a better option in cardiac patients as per Sapphire and CRUST trials. And simultaneous, both the surgeries, both procedures carry higher risk of strokes in the presence of concomitant disease. So it's just as a last, I just want to show one example, because most of the time we see in the clinical practice, because here is a elderly gentleman, 55-year-old gentleman who is hypertensive from 10 years, recurrent episodes of right upper limb paresthesias and weakness lasting 10 to 20 minutes. The problem is patient has right side symptoms, and MRI again showed the restricted foci on right MCA territory. So right side symptoms, right side infarcts. So, and this is the severe flow limiting region on the right ICA. So the problem is small plaque is there on the left ICA, so this cannot be the one that is causing the problem. So now the problem is which ICA is symptomatic. Most of the, I mean, some of the times we see it and we may be actually thinking, oh, if I treat it, what if the patient comes back? So here, since we want to document it, we have did a diffusion tensor imaging and demonstrated the uncrossed pyramidal tract by fiber tracking. So now the sequence of events are clear. It's a right ICA disease, right MCA territory infarct, and right upper limb weakness. So on the MR tractography, you can see the uncrossed pyramidal tract on both the sides, just different colors of right and left on varial multiplanar views. The uncrossed pyramids. This actually can be seen in a simple T2 weighted image also, but we require a high level of suspicion, and mostly it is actually clinically, because when we want to treat the this kind of lesion, we should be always, it's better to be careful, because once if we treat it in by mistake, if there is some other cause of the disease or the patient comes back with the recurrence, it's always better to document it. So he underwent right ICA stenting. Straightforward, pass the wire, and then the stent is placed across, and there is a good intracranial flow. So this is the first documented case of ipsilateral stroke with uncrossed pyramidal tracts because of underlying critical stenosis of ICA, and treated successfully. So in any case, let's not just the carotid stenting, is any case when we work, it's always better to see why am I doing it, what are the results might be, and will I be successful? Suppose if it is bilateral, is it worth to take both the risks? So it is always a simple logic, and when you think deeply and find satisfactory, we can answer these questions and we can go ahead. So this is my session. Thank you.
Thank you, madam, for a nice presentation of your original work. Now we invite questions from the audience. The virtual audience for the last session of the conference. The last session.
Madam,
Yes, please.
How frequently you see hyperperfusion, madam? It is in bilateral carotid disease,
Yeah, I'm
especially
sorry, I
in
forgot
tight
to mention
stenosis.
that. Actually, in both the series were done in different institutions. The first one was initially done in 2013, and later was the experience till 2019. The main concern was not the hyperperfusion. Till now, I had 2 cases of hyperperfusion. The main problem in bilateral carotid stenting, especially, was hemodynamic depression because of the baroreceptors on both the sides, and most of the patients were actually kept on dopamine or the supportive these things. But hyperperfusion per se is actually comparatively less, especially in the bilateral because of the poor cardiac reserve. But as long as we usually discontinue the beta blockers prior to the procedure, and we manage the blood pressure, and there is always anesthetic standby. So compare it to hyperperfusion. In my personal experience, or even with the experience of the teams with which I worked in the past, more than the if I have to worry, I'll worry more about the hemodynamic depression rather than about the hyperperfusion. But hyperperfusion is a nightmare because mostly, I mean, once it occurs, sometimes it can be small hemorrhages, but if there is a large hemorrhage, again it's nightmare. But it's always better to control good blood pressure control prior and then go ahead with the procedure.
Thank you, ma'am.
Thank you, madam. There are no questions to close the session.
Okay, thank you.
Thank you, sir. Thank you, ma'am. So we can close the session, and please join us for the validity function. Thank you.
Yes.
All of you can join us for the validity function in hall 3. You can access the validity function in hall 3 in another 10 to 15 minutes.